that?
Comment that came in, we said we'd pass it out to
Oh,
the members.
okay, thank you. Good morning. I want to ask all of us to please turn our cell phones to silent and make sure they're off the table so we avoid any unnecessary feedback. You may notice members accessing their laptops. They're doing so to conduct board business. This is an official meeting of the Medical Board of California, and as such, disruptions of the board's business will not be tolerated. We have a designated time on the agenda for public comment and ask for public comment on each agenda item. I ask that you be respectful for the need for the board to conduct its business. Should anyone disrupt the meeting, I will ask that person to conduct him or herself in such a manner that allows us to do our work. This meeting will be available via teleconference. Individuals listening to the meeting will have an opportunity to provide public comment and will be assisted by a moderator who will be facilitating the teleconferencing process. For those members of the public participating via teleconference, please wait until the moderator has introduced you before you make your comments. Assistance is available throughout the teleconference meeting. To request a specialist, press *0. To request to make a comment during the comment period, press *1. You will hear a tone indicating you are in the queue for comment. If you change your mind and do not want to make a comment, press the #sign. Each person will be limited to 3 minutes per agenda item. During agenda item 14, public comments on items not on the agenda, the board has limited the public comment period for individuals on the teleconference to 20 minutes. In addition, public comment from individuals here at the meeting will also be limited to 20 minutes. Therefore, after 20 minutes, no further comments will be accepted. During public comment on any other agenda item, 10 minutes will be allowed for comments from individuals on the teleconference line and from those in the audience. After 10 minutes, no further comments will be accepted. Business services staff will be assisting me with receiving public comments via teleconference during this meeting. The board welcomes public comment on any item on the agenda, and it is the board's intent to ask for public comment prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item and you wish to speak on that item, please raise your hand and you will be recognized. I would request that all speakers fill out a presenter slip, which I have an example of in my left hand, so I can call you by name at the appropriate time and that there will be an accurate record at today's meeting. However, filling out the speaker slip is voluntary, and so you don't have to. Please give the speaker slips to Ms. Toof. Ms. Toof, can you identify yourself? Good morning. I will do my best to call upon everyone who has supplied a slip for the agenda item and recognize those who wish to make any last-minute comments. I want to remind all speakers to stay on topic and to keep your comments to 3 minutes or less. I would like to call this meeting to order and ask that Ms. Toof please call the roll.
Dr. Bolat,
Present?
Dr. Bishop,
Here.
Judge Feinstein,
Present.
Dr. Gonadev,
Here.
Dr. Hawkins,
Here.
Dr. Kraus,
Present.
Ms. Lawson,
Here.
Dr. Levine,
Here.
Dr. Lewis,
Present.
Ms. Pines,
Here.
Ms. Sutton Wills,
Here.
Mr. Wormuth, Ms. Wright, Dr. Yip,
Here.
Mr. Serrano Sewell.
Present. A quorum is present. Thank you, and good morning. We will now move to item 14, public comments on items not on the agenda. I have no speaker slips, no speakers from the audience. Are there any comments from the phone on agenda item 14?
We have no questions at this time.
All right, thank you. Now let's move on to our next agenda item. Agenda item 15, discussion and possible action on legislative regulations. Ms. Simoes?
Good morning. Please refer to your legislative packets. You should have received an updated tracker list and one updated analysis. So on your tracker list, the bills in blue are either two-year bills or bills we've already taken positions on. The bills in pink are the board-sponsored bills, and the bills in green will require discussion and a position. Of note, as mentioned by Ms. Lawley, the bill to address the FTC issue has been introduced, SB 1195. This bill would grant authority to the Director of DCA to review a decision or other action of a board within DCA to determine whether it unreasonably restrains trade and to approve, disapprove, or modify the board's decision or action. And it would also add an additional standard for the Office of Administrative Law to follow when reviewing regulatory actions. We do not need to take a position, but there is a copy of the bill in your packets. So first, I just want to provide a quick update on our sponsored bills, and then we can move on to the bills that we need to take positions on. So AB 2745 Hill, that's the board's sponsored cleanup bill. That bill did pass out of Assembly BMP with no votes, and it passed out of appropriations on consent. And so SB 1039 Hill, this bill is the bill that clarifies that the Board of Podiatric Medicine is its own board and is completely separate from the medical board. For more than the past 2 decades, the BPM has been issuing its own podiatric licenses separate and apart from the board. It came to the board's attention that statute does not reflect this practice in all sections of law. So this bill will remove references to the medical board and the business and professions code sections that regulate the Board of Podiatric Medicine. It will make it clear that the Board of Podiatric Medicine is its own board that performs its own licensing functions. The board already voted to support that, and so it's actually got into a bill, SB 1039. That bill passed Senate BMP, and it's currently in Senate Appropriations. And lastly, SB 1478, this is the Health Omnibus Bill, and the provisions pertaining to the board just delete some outdated sections of law, and this bill did pass Assembly BMP, and it's now in, Senate BMP, and it's now in Senate Appropriations. So that's the sponsored bill update. Does anyone have any questions? Okay. So now I want to move on to the bills that we actually need to take positions on, so I can go in numeric order if there's a particular order the board would like me to go in.
Colleagues, I'd like to take just a couple of bills out of order. The first, well, not out of order. If we could take up Senate Bill 1033 Hill, Medical Board Disclosure of Probationary Status. There's no objection. Thank you.
Okay, SB 1033 Hill. Okay, this is the bill that requires the board, the Osteopathic Medical Board of California, the Board of Podiatric Medicine, the California Acupuncture Board, the Board of Chiropractic Examiners, and the Naturopathic Medicine Committee by July 1st, 2018, to include a standardized, single-paragraph, plain language summary that contains a listing of causes that led to the licensee's probation, the length of the probation and the end date, and all the practice restrictions placed on the license. This information is required to be included on any board documents informing the public of probation orders and probationary licenses, including but not limited to the board's newsletter. The summary information is also required to be posted on the Breeze licensee profile for each licensee subject to probation. This bill requires physicians and licensees of other named boards to disclose their probationary status to patients or their guardians or healthcare surrogates prior to the patient's first visit while the licensee is on probation, if the licensee was placed on probation for any of the following: gross negligence, repeated negligent acts involving a departure from the standard of care with multiple patients, repeated acts of inappropriate and excessive prescribing or controlled substances, drug or alcohol abuse that threatens to impair a licensee's ability to practice medicine safely, felony conviction arising from or occurring during patient care or treatment, and mental illness or other cognitive impairment that impedes a licensee's ability to practice safely. These licensees, including physicians, would also be required to disclose their probationary status to patients if their licensing board ordered any of the following in conjunction with placing the licensee on probation: that a third-party chaperone be present when the licensee examines patients as a result of sexual misconduct, that the licensee submit to a drug testing as a result of drug or alcohol abuse, that the licensee have a monitor, restricting the licensee totally or partially from prescribing controlled substances. Licensees would also be required to notify patients that they are on probation if they have not successfully completed a clinical training program or any exams required by the board as a condition of probation, or if they have been on probation repeatedly. This bill would require physicians or all licensees, including physicians, to obtain from each patient a signed receipt following the disclosure that includes a written explanation of how the patient can find further information on the licensee's probation on the board's website. This bill does provide an exemption if the patient is unconscious or otherwise unable to comprehend the disclosure and sign the receipt. In these instances, the licensee would be required to disclose his or her probationary status as soon as either the patient can comprehend the disclosure and sign the receipt, or their guardian or healthcare surrogate is available. So we do have, before I go into my recommendation, I did want to go kind of over, in the analysis, you'll see that we have a fiscal impact, and I just kind of wanted to run through that. So staff is estimating that this bill will likely result in more cases going to hearing because physicians will not want to agree to probation if they have to notify their patients. Board staff is estimating that cases that result in stipulated settlements of 3 years of probation or less will go to hearing instead of settling. So basically, those costs result to $1 million. And so that's kind of what our fiscal is. Now, there's been some talk with the author's office, and these amendments aren't in print, so I can't, bring them to you, but I want to just kind of run this idea by you, so if they do go in print like next week, we have a position on them. So one of the amendments that's been kind of been talked about to cover this fiscal impact is to allow cost recovery for physicians on probation, which means that if we were to put a physician on probation, we could recover those costs from the physician. Right now, we do not have cost recovery. A lot of other boards do. But the suggestion is that an amendment go in there to allow cost recovery for physicians on probation to cover these costs that I've just, in our fiscal impact. So I just wanted to bring that up so it can kind of be in our discussion. So if that amendment gets made soon, we'd still have a position that we can use. So just going on with my recommendation, the probationary status of a physician is public information available on the board's website. Ensuring that patients are informed promotes the board's mission of consumer protection. However, in emergency situations, it may not be prudent for physicians to provide this notification, as the instances in which a patient will not know who their physician will be prior to seeing that physician, including being assigned an anesthesiologist for a surgical procedure or being assigned to an OBGYN who is on call for labor and delivery, et cetera. Again, in these situations, a patient may not have the opportunity to make an informed decision. In addition, all healthcare consumers should have the same right to make an informed decision. It should not be dependent upon what type of healthcare practitioner is serving them. Therefore, all healing arts boards and licensees should be held to the same notification requirements. So board staff is recommending that the board take a neutral position on this bill. If it is amended to address the emergency situations and situations in which patients do not know who their physician will be ahead of time, and to require all healing arts boards and licensees to comply with the requirements. So now I would need a motion.
Thank you for that analysis. Before we take a motion, I think we'll have discussion first.
Okay.
All right. So, Dr. Kraus?
I have several concerns, the top of which is the burden that will be faced by the medical board, not just in terms of increased cost, but in terms of potentially being overwhelmed and falling behind and being able to discipline physicians and actually physically have the capacity to work through all of these hearings. I'm concerned that this will harm the public, because if the medical board can't do its job, many cases will be dropped. And I think that offers a greater harm to public protection than requiring the few hundred physicians who are on probation to notify their patients. Other than whether or not the medical board can physically do its job, should this bill pass, I'm concerned with the practical implication of a physician instituting this in his or her practice. The time consumed, not just in informing the patient, but in discussing the circumstances with the patient, would likely jeopardize the ability of that physician to stay in practice, and ergo our concern about physicians simply refusing probationary status. So, number one, I'm concerned that we would have a medical board that can't do its job. Number two, I'm concerned that it's impractical to institute. The irony is is that this is in our state legislature, and there's no state in the union that has this requirement. And Consumer Reports said we're already the best state in the union in terms of access to information about misbehavior of physicians compared to every other state in the union. So it's ironic that we, so to speak, have become a target state for this type of legislation. Thank you.
Dr. Kraus, thank you for your comments. Just want to add one thing to what you said, and that is, as I understood what you to say is in terms of dropping cases, your concern is that a physician would elect to go before an ALJ. That's the quote drop from, cases wouldn't be, they would continue, but they would go through a different process through the administrative law judge and not through a cure stipulation. That's what I understood your comment, and which others have voiced the concern that that would cause other delays.
Yeah, I'm just concerned that our system
Yeah.
of discipline would not be able to keep pace with the number of cases that need to be processed.
Yeah, thank you. Doctor?
Mr. Mosa, you did a really great job in doing the analysis. Just like most of the board members, I'm very concerned too. I'm a surgeon, okay? So I give you two examples. I'm a vascular surgeon. I schedule an angiogram in radiology. That radiologist just comes on, sees the patient about 10 minutes before he performs the procedure. So this patient is already extremely nervous. Or the operating room. The anesthesiologist, many times in a large hospital like ours, they get assigned on the same day. They don't need the patients. Someone from their team saw the patient, but that assignment is that morning. Just imagine you going into the operating room and a doctor comes and tells you, oh, by the way, ma'am, goes on and on. That's just a disaster in my mind for anyone's health, anyone's safety. It's just not a right way to do. I think it's a bad way to do. But your analysis is very good. And also, why pick only physicians? Pick physical therapists, pick nurses, pick nurse practitioners, pick PAs, pick optometrists, pick every healthcare provider if you want to pick, and really go into a place where you make, you make really problem with the healthcare in California. So, but I support what you're recommending.
Dr. Hawkins, and then I'll look to my left.
So as not to be too repetitious, I just want to remind everyone that we had deliberated at some length the last board meeting talking about the notification of probationary status, and there was a great deal of discussion about adverse consequences. I'm not going to repeat those.
Thank you, Doctor. Looking to my left, are there any comments? No? Okay. I would echo the comments that the staff recommendation is well-balanced and something that I would support as well. But now let's go to public comment. That's all right, and then we'll take a motion? Yeah, that's fine. So our motion can be informed by public comment. All right. I have Carmen Balber, I think, Ms. Hollingsworth, Ms. Monserrat Ramos, Ms. Chong as the speakers. You can please come to the microphone. Good morning.
Good morning, board members. My name is Michelle Monserrat Ramos. I'm here on behalf of Consumers Union Safe Patient Project. Regarding SB 1033, we urge the board to support this legislation. Disclosure of probationary status by physicians to their patients is the most effective way to keep patients safe and to achieve the board's policy that all California consumers should know the background, training, certification, and history of disciplinary actions of any healthcare provider they consider seeing. This is not the same proposal that the board turned down last year and responds to board concerns articulated last October. The bill requires physicians who are on probation for serious issues to inform their patients, provide a simplified method of disclosure, and include a similar requirement for other primary health care practitioners. Thank you.
Thank you for your comments.
Carmen Bulver with Consumer Watchdog. I would just like to reiterate the call that we've made in prior board meetings that the board reconsider this position on whether or not physicians who are accused of the most serious disciplinary actions, from sexual abuse of a patient to using drugs or alcohol on the job to being so grossly negligent that they cause the death of a patient, that they shouldn't be required to tell their patients of that safety history. It's the height of hypocrisy for the board to be spending all of this time and money and effort in a public education program to inform the public about how they can look up the same information on the Breeze system, but be opposed to giving it to consumers in the cheapest, easiest fashion at the point of care. In fact, you could probably use the money you'll be saving on not promoting that Breeze system to pay for any added enforcement you might have. So we would urge you to reconsider this key patient safety measure.
Thank you.
Good morning, Yvonne Chung with the California Medical Association. We encourage the board to approve the staff recommended amendments. However, we would urge you to take an oppose unless amended position. It should be clear that you are not neutral, but are in fact opposed without the amendments. Also, we note that the staff fiscal analysis suggests cases that would result in a stipulated settlement of more than 3 years would still be stipulated under the bill. We disagree with this assessment. The practical impact of the bill's requirement on a physician's practice, because of the time required to implement the notification, would basically be equivalent to a suspension, and physicians will have much less incentive to settle, regardless of the length of probation. So we think that the fiscal impact will actually be much higher than the $1 million stated by staff. Thank you.
Thank you. Please.
Good morning, Bridget Grammy with the Center for Public Interest Law. For the new board members, the Center for Public Interest Law is a nonprofit and nonpartisan academic and advocacy center at the University of San Diego School of Law. And as Julie Felmuth, our administrative director, mentioned yesterday, our CPIL has monitored this board and other state regulatory agencies for the past 35 years. And we advocate for public protection before these boards, and we train our law students to do the same. CPIL strongly supports SB 1033 for the reasons that the Consumers Union already stated, but also we have a different reason, and that's because the medical board's probation unit is charged with monitoring physicians on probation and detecting any violations of probation so that the board can take appropriate action. The probation unit, now comprised of non-sworn probation inspectors, has double the caseloads of the peace officer investigators who investigate the medical board cases. They have to monitor compliance with all terms and conditions of approximately 520 probationers at any given time, and there are sometimes over a dozen terms and conditions of probation in each order. Within the past several years, the probation unit has been unable to keep up with this incredibly large caseload. We have seen many petitions to revoke probation, documenting probation violations going back a year or more. Yet these petitions have not been filed promptly, and these probationary doctors have been permitted to continue practice. The board's paramount priority is public protection, yet each time the board's probation unit fails to act promptly on probation violations, patients are at risk. While we know that the probation unit is under new supervision and its performance may be improving, the caseloads of the probation inspectors and the board's historical failure to promptly file petitions to revoke probation makes it even more compelling that patients be affirmatively notified that their doctor's on probation so they can make an informed choice about their physician. For all of these reasons, CPIL urges you to support 1033. Thank you.
Hold on. Thank you for your comments. Are there any other additional, Ms. Hunt, did you care to speak? Oh, okay. Got it. All right, thank you. Are there any additional comments from the audience? Seeing none, we'll go to the phone. Are there any comments on the phone on Senate Bill 1033?
We have no questions over the phone.
All right, thank you. Colleagues, is there a motion? Dr. Lewis?
I'd like to make a motion that on Senate Bill 1033, we recommend a neutral position if amended.
Thank you. Is there a second? Second by Ms. Wright, thank you. No additional comments. Ms. Toof, oh yes, Dr. Bishop, please.
As I listened to all the comments today, something that dawned on me was something that came up yesterday in our panel, and that is the longer we take to resolve a case, the longer that physician has no supervision whatsoever. So if we take a position that allows, that creates a situation where the physicians and their legal counsel do not resolve a case quickly, that prolongs the time that physician is under absolutely no supervision, no probation, no watchdog whatsoever. So I think we need to be cautious as we move forward. I mean, I think the point is very good. I would want my family to know if the physician had done terrible things too. I understand that. So I'm mixed on this, but I think that unintended consequence could be very severe because we try very hard to craft probationary terms which we believe protect the public. And the implication here is that although we've crafted these, we're not doing our job, and so these people are dangerous. I don't know, perhaps Ms. Kirchmeier can tell us, perhaps there's data, what the incidence of a physician harm from a physician who's on probation. I suspect it's not terribly high, but I'm sure it exists, and we want to prevent that. But I just think that we have to consider the risk-benefit of a position like this, because the longer that physician is out there doing harm, the longer we can't get them on probation and craft some terms that protect the public, they are a loose cannon. So just want to point out that law of unintended consequences. Thank you.
And that's a very important point, Dr. Bishop, and that point has been expressed to the author and his staff. And so it's out there, people know. Are there additional comments from the members? No? Seeing none, Ms. Toof, can you please call the roll?
Dr. Bolat? Aye. Dr. Bishop? Aye. Judge Feinstein? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
No.
Ms. Lawson?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines?
Aye.
Ms. Sutton Wills?
Nay.
Mr. Wormuth?
Aye.
Ms. Wright?
Aye.
Dr. Yip? Mr. Serrano Sewell?
Aye, the motion carries. Thank you, colleagues, for taking this up. Let's move to the next item.
Do you want me to start at the top now?
Assembly now.
Okay. Okay, the first bill, AB 1977 would. This bill would establish an opioid abuse task force to develop recommendations regarding the abuse and misuse of opioids. This bill would require on or before February 1st, 2017, healthcare service plans and health insurer representatives, in collaboration with advocates, experts, healthcare professionals, and other entities and stakeholders, to convene a task force. The task force would be required to develop recommendations regarding the abuse and misuse of opioids as a serious problem that affects the health, social welfare, and economic welfare of persons in California. This bill would require the task force to submit a report detailing its findings and recommendations to the governor, the president pro tem of the Senate, the Speaker of the Assembly, and the Assembly and Senate Health Committees by December 31st, 2017, and the task force would be dissolved by June 1st, 2018. This bill furthers the board's mission of consumer protection and is in line with the board's work on the important issue of preventing misuse and abuse and inappropriate prescribing of prescription drugs. Board staff thinks the issues assigned to the task force would be helpful to the board's work as well, and board staff would like to participate in the task force if this bill is signed into law and to ensure the discussions are in line with the board's guidelines. Board staff suggests that the board support this bill, but I need a motion.
Okay,
So moved.
so moved. Is there a second?
Second.
Thank you. Are there any comments from the members? Seeing none? Oh, wait, I'm sorry, apologize.
This way. Thanks, David. This is actually, in my mind, the biggest problem we got, public safety-wise. And it's even going beyond now, actually. It's going beyond the prescription drug opioid abuse. Actually, the fentanyl coming into market illegally from China is just getting to be as big or bigger problem fairly soon, and it just scares me to death what's going on. The mentally ill or young people stressed out just die for no reason. So I think it's very important. We got to do whatever it takes.
Absolutely. Dr. Levine?
Yeah, I think this is a great idea, and I think the good news also is that so much work has been done already. The CDC has just recently issued guidelines, the work of our own prescribing task force, so that I think there's a tremendous amount of work for the task force to call upon, and by doing this within the state, it really will enable it to have a California visibility and flavor that will highlight the issue even more.
Thank you. Are there additional comments from the members? Seeing none, I'll take public comment, but there was a motion and a second to approve. Are there any comments from the audience? Seeing none, are there any comments from the phone on Assembly Bill 1077? Or 19...
No
what is it?
comments over the phone?
1977. No comments from the phone. Ms. Toof, can you please call the roll?
Dr. Bolat? Aye. Dr. Bishop?
Aye.
Judge Feinstein? Dr. Gonadev?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Aye.
Ms. Lawson?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines?
Aye.
Ms. Sutton Wills?
Yes.
Mr. Wormuth? Ms. Wright?
Aye.
Dr. Yip?
Aye.
Mr. Serrano Sewell?
Aye. Motion carries. Next item.
So the next tab you have is AB 1992, but that bill actually died, so we're going to move on to the next one.
Okay.
AB
Rest in
20,
peace.
AB 2024 would authorize until January 1st, 2024, a federally certified critical access hospital to employ physicians in charge for professional services. This bill would specify that the critical access hospital must not interfere with, control, or otherwise direct the professional judgment of a physician. This bill would require the legislative analyst on or before July 1st, 2023, to provide a report to the legislature regarding the impact of this authorization. The board has always believed that a ban on the corporate practice of medicine provides a very important protection for patients and physicians from inappropriate intrusions into the practice of medicine. That being said, critical access hospitals are in remote rural areas, and this bill would help these hospitals to recruit and retain physicians, which will improve access to care in these rural communities. In addition, this bill is a pilot program that will be evaluated, and the bill makes it clear that the critical access hospital must not interfere with, control, or otherwise direct the professional judgment of a physician. As such, board staff is suggesting that the board take a neutral position on this bill. I would need a motion.
Is there a motion? Moved by Dr. Bishop, seconded by Dr. Lewis. Is there any comments from the members? Seeing none, are there any comments? Oh, yes, Dr. Kraus.
I agree with the neutral position. I want to take a moment to remind ourselves and others that not every state has a corporate bar in the practice of medicine, and we need to look at lifting these as a potential for a slippery slope, although I have no objection to this bill. And the main concern is to always assure that the physician's primary interest is his or her patient, and that he or she is not serving the interests of an employer.
Thank you. Are there additional comments? Okay, seeing none. Are there comments from the audience? No comments. Are there comments from the phone?
We have no questions over the phone.
All right, thank you. Ms. Toof, can you call the roll?
Dr. Bolat? Aye. Dr. Bishop? Aye. Judge Feinstein?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines? Ms. Sutton Wills?
Yes.
Mr. Wormuth? Ms. Wright?
Aye.
Dr. Yip? Mr. Serrano Sewell?
Aye. Motion carries.
Great. Okay, AB 2216 Bonta. This bill would establish the Teaching Health Center Primary Care Graduate Medical Education Fund in the State Treasury and would require the Director of the Office of Statewide Health Planning and Development to award planning and development grants from the fund to teaching health centers for the purpose of establishing new accredited or expanded primary care residency programs. This bill would provide that the grants must not be for more than 3 years and that the maximum award to the teaching health center must not be more than $500,000. This bill will increase funding for residency programs in California, which will help promote the board's mission of increasing access to care for consumers. And board staff is suggesting that the board take a support position on this bill.
Thank you. Is there a motion?
So moved.
It's been moved.
Second.
Second. Thank you. It's a discussion from the board members. Yes?
It's a great bill. I think we should do whatever it takes to increase the GME. Remember that most of the graduate medical education portions are concentrated in the East Coast. There are so few in California. The population grew in the West by doubled almost in the last 40, 50 years, but the GME portions haven't changed a lot because CMS has a cap on from 1997. They won't pay for any more if a hospital increases. Like my hospital has 180 GME portions, only 110 are funded. Loma Linda, about half of them are not funded. So it's time that state of California somehow or other come up with some money to really fund these portions so that these kids, when they do their residency, they have 70% chance of staying in the local area. So this is such an important issue, I just want to point out.
Thank you. Dr. Kraus?
Also speaking in support, I'd like to again remind us that California is doing a good job in terms of increasing the number of medical school seats. But statistical analyses have shown that the greatest probability of site of residence and practice of a young physician is not where he or she went to medical school, but where the residency was done. And we have fallen behind in residency slots, so that many of our California medical school graduates must leave the state for residency and don't come back. So I think it's critical that we address this and support this bill.
Dr. Lewis?
What this doesn't address is, the elephant in the room is the federal government. And it'd be interesting if we could have some way to lean on the federal government, with bills like this, and go to our, U.S. legislators and state our case. But, that's the bigger issue, is the federal government, lack of funding for these programs.
Thank you. I see no additional comments. Are there any comments from the audience? Seeing none, are there any comments from the phone?
We have no comments over the phone.
All right, thank you. Ms. Toof, can you please call the roll?
Dr. Bolat? Aye. Dr. Bishop? Aye. Judge Feinstein? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins? Dr. Kraus?
Yes.
Ms. Lawson?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines?
Aye.
Ms. Sutton Wills?
Yes.
Mr. Wormuth? Aye. Ms. Wright?
Aye.
Dr. Yip? And David Stroessel.
Aye. Motion carries. Next
All right.
item.
Next bill, AB 2507, Gordon. This bill would specify that the definition of telehealth includes video and telephone communications. This bill would allow the acceptable forms of prior consent to include digital consent, in addition to the verbal and oral consent allowed in existing law. This bill would prohibit healthcare providers from requiring the use of telehealth when it is not appropriate. This bill would specify that a patient shall not be precluded from receiving in-person healthcare delivery services. This bill would also provide a telehealth reimbursement infrastructure and would require the same coverage and reimbursement for services provided to a patient through telehealth as is required when the patient receives equivalent services in person. This bill would specify that all laws regarding the confidentiality of healthcare information and a patient's right to his or her medical information shall apply to telehealth services. Board staff believes that changes in this bill would make to existing law will not have a negative impact on consumer protection and may increase access to care. Board staff recommends that the board take a neutral position on this bill.
All right, thank you. Is there a motion? Judge Feinstein? Absolutely.
I don't understand the recommendation for a neutral position.
So, just adding these video and telephone, we could go support, we definitely wouldn't want to go oppose, but neutral, in the past on these telehealth bills, we've usually taken a neutral position, so that's where I kind of started from, but if the board wants to support it, that's the board's call to decide to go to a support position. Staff looked at it as like increasing, it's a slight expansion on telehealth, and we didn't think that slight expansion would have a negative impact, but we didn't know if the board would want to go so far as to support it, but if you do, you definitely can.
Dr. Levine, did you?
I think this is a good thing.
Yeah.
I
The
said, I think
support?
it's a good thing. I mean, I think,
For communities where access to, seeing a doctor in person is an obstacle for whatever reason, it seems to me that this could be quite beneficial, at least in pre-screening whether somebody does need to make a long trek somewhere to be seen. I can't figure out what the negative of it would be so that we wouldn't support it.
Yeah, just so you know, neutral's not a negative position.
No,
It's
no,
just
that's, I think
basically- yeah.
you're asking a question a lot of us were thinking.
Yeah. You could definitely.
Dr. Levine, could you provide us your insights?
Yeah, so there are, as we speak, there are many video visits that are occurring, and I would argue that downtown San Francisco and downtown Los Angeles are two areas that are very difficult to get to in terms of commuting. It's not just rural hospitals. Video visits are an incredible patient pleasers, to be honest. I'm a pediatrician, and the ability to have a pediatrician evaluate a rash and not have to bring a 2-year-old into a doctor's office is a real boon to parents. What this bill does, which is I think where the opposition comes from, is it makes clear that physicians should be reimbursed for video visits as they are for in-person visits. And it looks like the California Association of Health Plans, AHIP, the chamber are opposing this, I assume, because of the fiscal impact. But to expand, include video visits, which are already happening in telephone communications, makes perfect sense. The details of who gets paid how much for what clearly need to be worked out, but I think directionally, this bill is absolutely going in the right direction.
Pursuant to
Dr.
that,
Kraus, and
oh, I'm
then
sorry,
we'll-
go on.
I'll start with Dr. Kraus and then Dr. Bishop. Thank you.
If we would entertain a support position, I wonder if you would want support if amended, and that is there any concern that in the expansion of telehealth, that it could be used in place of a first in-person visit for obtaining opioids, other controlled substances, or marijuana, or should we just leave this bill as is and move to support?
As is in support.
I believe.
Dr. Bishop?
It looks to me like that may be addressed in here. It says the bill would prohibit health care providers from requiring the use of telehealth when it is not appropriate. They might change the word requiring to something else, but I was just going to say, for the sake of further discussion, I would make the motion that the board, support the bill.
Is there a second?
Second.
There's a second to the motion. Dr. Levine?
Yeah, I believe, looking at the language of the bill, that all this does is add video and telephone. It does not expand
Right.
beyond the protections that were in the prior bill that was passed in telehealth.
That's my understanding. Ms. Kirkmeyer?
And of course, any complaint that we get, we would look at it from the standard of care perspective is where we'd be coming in. So we'd have the expert that looked at it to determine, okay, was that communication, no matter what it was, is that in the standard of care, and then take appropriate action from that point.
It's always a good faith prior exam. It comes into effect in every.
All right,
in
thank you.
everything.
There's been a motion and a second to support Assembly Bill 2507. Thank you for that discussion. Is there any comments from the audience? Are there any comments from the phone?
No comments over the phone?
All right, thank you. Ms. Tuve, can you please call the roll?
Dr. Bolat? Aye. Dr. Bishop? Aye. Judge Feinstein?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines?
Aye.
Ms. Sutton Wills?
Yes?
Mr. Warmoth?
Aye.
Ms. Wright?
Aye.
Dr. Yip? Mr. Serrano Sewell.
Aye, the motion carries. Thank you. Next item.
All right, AB 2592 Cooper. This bill would require California Department of Public Health to establish a pilot program if funding is available to award grants to combat opioid abuse through the safe prescribing of opioids. CDPH would determine the amount of grants to award to individual pharmacies that choose to participate in the program. Grants must target areas where the prevalence of prescription drug abuse is high, as determined by data that has been collected by CDPH and the California Healthcare Foundation. A pharmacy that applies for and receives a grant would be required to offer all patients who are prescribed an opioid a medicine locking closure package. A patient would not receive the medicine locking closure package unless he or she consents either orally or in writing. The bill would define a medicine locking closure package as a locking closure container unlocked only with a user-generated code that only allows the person with the prescription to access the medicine. A medicine locking closure package includes an amber prescription container combined with a resettable alphanumerical code. This bill would specify that CDPH shall not expend general fund monies on this program unless those monies are specifically appropriated for this purpose. This bill would allow CDPH to seek funds from private entities, including foundations and nonprofit organizations, and CDPH may apply for federal or other grants to fund this pilot program. CDPH would be required to evaluate the effectiveness of the pilot program and report its findings to the legislature by December 31st, 2019, and the pilot would be sunsetted on January 1st, 2020. This bill furthers the board's mission of consumer protection and is in line with the board's work on the important issue of preventing misuse and abuse of prescription drugs. For these reasons, board staff suggests that the board support this bill.
Is there a motion?
I'll make a motion to support.
Second. Second, thank you.
I have questions.
Yes, please.
Ms. Amos, who are these people they're supporting? Are those the companies which
Yeah,
make
it's a
the-
company, yeah. Basically, it's like a medicine bottle with like a combination lock on the top. And you probably know CDPH just did recently get a lot of grant funding for the whole opioid issue, so that's kind of why they're going to CDPH for this. But it's actually a good idea, and it's an opt-in, so pharmacies don't have to do it. If they want to do it, they can. And if a patient that receives an opioid wants to receive that medicine lock, it's opt-in all the way, so it's not a requirement for the patient or for the pharmacy. And really what they're looking at is the data in the report to show if it helped at all in those areas.
So do we know how much it adds additional cost to the consumer?
It wouldn't be a cost to the consumer because it would be grant funding to cover the cost, so it couldn't be passed on to the consumer.
Is that clear in the bill? That
Yeah,
there's
yeah, it says that it has to be, that the grant has to cover the cost of those medicine locking closure.
So, sorry.
No,
but-
please.
That's okay.
So this is essentially a research project.
Essentially with grant monies, and the pharmacy basically says, I wanna be involved in this, and they get those grant monies to get those medicine locking closure bottles.
So then I would suggest a support if amended position to ensure that this is in fact constructed not as a pilot program, but as a legit, or as a pilot program with legitimate research hypothesis. So in fact, what we're not doing is using funding to do market research thinly veiled as a research project. I worry about how the conclusions are going to be drawn at the end as to whether this made a difference. So that I would certainly hope that if we're expending these dollars,
When does it sunset?
it isn't just about grant funding to promote a product without the ability at the end of the time to actually draw legitimate conclusions about whether this made a difference.
Well, and just, it's actually the Department of Public Health evaluating the effectiveness, not the actual manufacturer. So it's a state department looking at it and taking their data to see if things have improved. So I don't know if that makes a difference.
Well, what makes a difference is there a real control? Is there in fact a research design that enables you to compare it to something else? And,
Ms. Kirkmeyer?
So what language would you recommend we amend it to? Because, I mean, it has a report that they have to put together, it sunsets the bill. I mean, I think it's covered in here, so I'm just wondering what amendments we would put forward.
that the pilot be constructed with appropriate matched controls so that the Department of Public Health can, in fact, determine at the end of the pilot project whether, in fact, this has had an impact and enhanced consumer safety.
I think it's too much.
Dr. Levine, would you be comfortable if we included those very comments in our communication to the author?
Sure.
With the support motion? Would you be?
Sure.
Okay, thank you. So the support motion can stand with the comments that Dr. Levine has made. So we're very clear to the author that we know that the bill sunsets, we know the state has to perform an analysis, but it is our strong recommendation that it be scientific in its approach. So, are there any comments from the audience? Oh, Dr. Hawkins.
I
Thank
just
you.
have a question. Does anyone know if the opioid abuse task force has talked about any of these type of approaches to access or use or misuse of opiates? Does that come up at all?
No, I don't think we've actually even brought this issue. This bill hasn't come before the big task force that we have. It's something, though, with it going through the legislative process, and yesterday when I was talking about the 4 different task forces that are being put together, this actually should fit into one of those, especially if CDPH has to take it on, because that's who leads those task forces.
All right. Seeing no additional comments, is there any comments from the audience? Yes.
Carrie Sparrow Vaughn, licensed midwife. Perhaps this is already something that you all know, but the only target audience I see for this are people who have an opioid prescription and an abuser in the home. Because many people are getting their opioid prescriptions and going out on the street and selling them. Well, they don't need a locking container because they're going to sell them anyway. And it just seems to me that the people who are going to actually opt into this, the numbers are very small.
This bill is actually attempted to address the adolescents, the homes, and it's particularly geared toward adolescents and homes, the opioids being in the home and them having access to that medicine.
All right.
David, could I, since we've...
Yes, Dr. Bishop.
My concern is similar to that unless this device is something that's bolted down or bulletproof, what prevents the adolescent from just taking the whole device out and by hitting with a hammer and taking the narcotics out? I'm just
Actually,
saying,
I did ask him that, and the
Yeah.
point is, you would know that you come home and your medicine bottle is hit with a hammer, you know that your
well, but
child
it doesn't
is
matter.
getting
They've already taken the narcotics. So it's kind of a moot point.
I think
It
it's
seems
more of like a
silly
way
thing.
to let the parents know what's happening. That's how they explained it to me anyway.
Okay,
They can do
thank
that
you.
with a dye pack.
Thank you, Dr. Bishop. Thank you. Are there any comments from the audience? Seeing none, are there any comments from the phone on Assembly Bill 2592?
No questions over the phone.
All right, thank you. Ms. Toof, please call the roll.
Dr. Bolot?
Aye.
Dr. Bishop? Judge Feinstein?
Nay.
Dr. Gonadev?
Abstain.
Dr. Hawkins?
This is with the amendment, right? The support with,
It's Dr. Levine was comfortable with the support position having a communication to the author that it can incorporate her comments about the study and the rigorous nature of the study,
yes,
and that it have some finding that it actually enhances consumer protection.
yes.
Yes, thank you.
Dr. Kraus?
Aye.
Ms. Lawson?
No.
Dr. Levine?
Abstain.
Dr. Lewis?
Aye.
Ms. Pines? Aye. Ms. Sutton Wills?
Yes.
Mr. Wormuth? Aye. Ms. Wright?
Abstain.
Dr. Yip? Mr. Serrano Sewell?
I'm going to have to confer with the executive director to go through the votes.
Dr. Yip, I'm sorry, I missed your vote. What was it? You have 8, Lisa? 8 for yes?
Did Dr. Yip say yes or nay?
He said nay. Dr. Yip voted nay. No.
I apologize, I marked that
all right.
incorrectly.
I have 8 votes, so it will pass.
Thank you.
I agree.
Next item.
Okay. Okay, AB 2606 Grove would require a law enforcement agency that receives or makes a report of the commission of specified crimes by a person who holds a state professional or occupational license or permit, allowing the person to provide services to children, elders, dependent adults, or persons with disabilities, to provide a copy of that report to the state agency which issued the license, including the medical board. Board staff believes that this information would be very helpful to the board to identify physicians that could possibly pose a threat to vulnerable consumers and need board review. Once the board receives this information, it would still go through the board's normal complaint and investigation process, which is confidential. This bill was recently amended, but the amendments were minor and do not impact the board's analysis. So board staff is suggesting that the board support this bill.
Just a question. Jennifer, does this apply to Micra?
No, it's just like a law enforcement report, yeah. No, it doesn't apply to micro.
Are there any additional questions or comments from the members? Is there a motion?
So move.
So move to accept, to a
Second.
support?
Second?
Second, Dr. Levine, thank you. I see no additional comments from the members. Are there any comments from the audience? Seeing none, are there any comments from the phone?
No comments over the phone.
All right, thank you. Ms. Tuve, can you please call the roll?
Dr. Bolat? Aye. Dr. Bishop?
Aye.
Judge Feinstein? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Aye. Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines?
Aye.
Ms. Sutton Wills?
Yes.
Mr. Warmoth? Ms. Wright?
Aye.
Dr. Yip?
Aye.
Mr. Serrano Sewell?
Aye, motion carries. Thank you. Next item.
AB 2744 Gordon. This bill would expressly provide that payment or receipt of consideration for advertising where a licensee offers or sells services on the internet shall not constitute a referral of patients. This bill would require the licensee to fully refund the purchaser if, after consultation, the licensee determines the service is not appropriate for the purchaser. This bill would specify that it does not apply to basic health care services or essential health benefits. This bill would require the entity that provides the advertising to demonstrate that the licensee consented in writing to the requirements of this bill. Board staff has already looked at the issue of internet advertising for physicians with companies like Groupon and Living Social and does not believe that these arrangements are in violation of existing referral law. This bill would make it clear that this type of advertising is not in violation of existing law and would add protections for consumers to be refunded if the service is not appropriate. For these reasons, board staff suggests that the board take a neutral position on this bill.
Are there any comments or questions from the members? Seeing none?
No, I do.
Yeah, Dr.
I'm
Bishop?
sorry, as an old person, I've never used Groupon. Can you explain exactly what they're asking for here? I'm just confused, and I apologize for that.
So they're just making sure that there's existing law related to referrals and kickbacks.
Just give me an example of what they want to do that would not be
So
prohibited.
they're just basically, like, you know, when you see, oh, you don't, on Groupon. Okay, so sometimes you'll see like, sometimes
Know the
you'll see,
Sunday
like-
paper? They have coupons in the Sunday paper. That's what Groupon
Sometimes you'll
is.
see like, oh, like Botox or something, or like cosmetic kind of stuff, and it will go on Groupon, and it will say it's for a certain price, and it's kind of like the newer system of like, you know, Yellow Pages or coupons or whatever, but it's allowing that on the internet through places like Groupon or Living Social. And the way they've kind of set up their infrastructure, board staff has already looked at this in the past, and we don't believe that it violates existing law, but this bill just makes it really clear that it doesn't violate existing law.
So, for example, I might put a coupon on Groupon saying your anesthesia charges are 20% off today or something like that. Is
Well,
that?
it's-
Your
I'm not sure you
liposuction.
could do it for anesthesia. It's like, it
Well,
can't
I'm
be
just
for
an example.
Fillers.
essential health services or basic
Plastic
healthcare
surgery.
services. It's only like elective, yeah.
Yeah.
I was just gonna say, you actually pay for the service right there.
Yeah.
And so you purchase it, and then you
Oh.
take that and go have it
Yeah.
done, basically.
Can I make a clarifying comment that on page 98, they did strike out that the licensee shall provide the refund if the patient is not appropriate for the visit. And so that would force the patient to go back, I suppose, to Groupon to try to get the refund.
All right.
Which Groupon does refund?
All right. Satisfied
I wouldn't
customer.
know.
Dr. Kraus?
I wanted to clarify for Dr. Bishop and other senior citizen members.
including you.
That the difference between Groupon and coupon is that coupon is part of a paid advertisement. So
Yeah.
a physician or healthcare provider pays for the advertisement. Groupon is actually fee splitting. And that's why there is this need for an allowance of that form of fee splitting by legislation.
Thank you. Is there a motion?
I move
Moved for the neutral
for the
position?
to
All right.
recommend the neutral position.
Is there a second to that? Thank you. Are there any comments from the audience? Seeing none, are there any comments from the phone?
No questions over the phone.
Please call the roll, Ms. Toof.
Dr. Bolat? Aye. Dr. Bishop?
Aye.
Judge Feinstein?
No.
Dr. Gonadev?
Abstain.
Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson?
Abstain.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines?
Aye.
Ms. Sutton Wills?
No.
I'm sorry?
No.
No, thank you. Mr. Warmoth?
Abstain.
Ms. Wright? Dr. Yip?
Aye.
Mr. Serrano Sewell?
Aye. Motion carries. Next item.
Okay, SB 22, Roth, Cannella, and Galgiani. We actually looked at this bill before. It's a 2-year bill. It was substantially amended since the last time we took a position on it, and we supported it before. This bill would continuously appropriate $300 million from the general fund over a 3-year period to Office of Statewide Health Planning and Development for the purpose of funding new and existing graduate medical education physician residency positions and supporting training faculty pursuant to the Song-Brown Healthcare Workforce Training Act. This bill would increase funding for residency programs in California, which will help promote the board's mission to increasing access to care for consumers. It would also allow more physicians to receive residency training and potentially end up practicing in California. As such, board staff suggests the board support this bill.
Thank
So
you.
moved. Support.
Second.
There's been a motion and a second to approve. Are there any comments from the members? Looking to my left, to my right, seeing none, thank you. Any comments from the audience? Are there any comments from the phone?
No comments over the phone.
All right. Ms. Toof, please call the roll.
Dr. Bolat?
Aye.
Dr. Bishop?
Aye.
Judge Feinstein?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines?
Aye.
Ms. Sutton Wills?
Yes.
Mr. Warmoth? Aye. Ms. Wright?
Aye.
Dr. Yip?
Aye.
Mr. Serrano Sewell?
Aye, motion carries. Next item.
Okay. Next bill, SB 482, Lara. This is one that we talked about previously, and we were supportive of. There was some amendments taken. So this is the bill that requires all prescribers issuing Schedule 2 and 3 drugs to access and consult cures before prescribing a Schedule 2 or 3 controlled substance under specified conditions. This bill would specify the prescriber is not liable in a civil action solely for failing to consult the cures database. What was added is basically exemptions to this requirement. So it would specify that the requirement to consult cures does not apply if any of the following conditions are met, and this is what was added. The cures database is suspended or inaccessible. The internet is not operational. The data in the cures database is inaccurate or incomplete, or it is not possible to query the cures database in a timely manner because of an emergency, or if the controlled substance is prescribed to a patient receiving hospice care, the controlled substance is prescribed to a patient as part of a surgical procedure that has or will occur in a licensed healthcare facility and the prescription is non-refillable, or the controlled substance is directly administered to the patient by the prescriber or another person authorized to prescribe a controlled substance. This bill would specify that it is not operative until DOJ certifies that the cures database is ready for statewide use, and DOJ would be required to notify the Secretary of State and the Office of Legislative Counsel of the date of that certification. This bill only requires the cures database to be checked for an initial prescription of a Schedule 2 or 3 controlled substance on an annual basis if that controlled substance is still being prescribed, or if the same controlled substance has already been prescribed. This bill would also ensure that the cure system will have the capacity to handle this workload before the bill becomes operative. This bill would further the board's goal of consumer protection and take steps forwards in addressing the issue of doctor shopping and opioid abuse. For these reasons, board staff is suggesting that the board support this bill.
I have one. Oh, Ms. Kirkmeyer, did you want to comment?
I just wanted to let everyone know to put on the record that the handout that was handed out earlier, and there's also copies in the back, is a public comment that came in written form that we said we would pass on to all of the members, and it's in support of checking that, so.
All right, it'll be included in the record. I have one speaker card, Ms. Chung, I think. And then we'll take member comment and motions.
Good morning, Yvonne Chung, California Medical Association. SB 42 was amended to expand the exemptions from the blanket duty to consult in the previous version of the bill. We agree that the previous language failed to take into consideration the many situations in which a duty to consult would not make sense. However, the exemptions as drafted are problematic. For example, the language provides an exemption for checking when the prescription is prescribed for surgery in a licensed facility. We agree that a mandatory consultation doesn't make sense when the prescription is for surgery. However, the language excludes surgery performed in an outpatient surgery setting. Additionally, the language attempts to provide an exemption for administration in inpatient settings. Again, this exemption makes sense, but the mechanism for doing it is flawed. The exemption is provided when the controlled substance is being directly administered to the patient by the prescriber or another person authorized to prescribe a controlled substance. In a hospital, it's likely the person administering the prescription is a nurse who would not be eligible to prescribe, thus essentially requiring a consultation. Additionally, we believe that there must be a third party that certifies that the database is ready for statewide use. CMA and the medical board have been working with physicians as they work to get registered on the system, and there have been many issues with the process. We've also been receiving questions and concerns about the system itself, and we feel the system must meet the needs of clinicians if we are to mandate that they check it. The duty to consult and vision despair will impact patient care. The way this gets done matters, and the mechanics matter. We strongly caution against supporting this bill based on a conceptual idea without a keen attention to the details. Thank you.
All right, thank you for your comments. Yes, please.
I would just add a couple of things. Is it on? I would just add a couple of things. One, I think that the Attorney General's office has been here several times to update the board on how Cures is functioning. They're extremely pleased with the way it's working. And although we know that the California Medical Association has, for many years now, been strongly opposed to the mandatory use of Cures, and claiming technical difficulties is an easy way for them to object to its mandatory use, we are hearing time and again that the database generally works. The biggest problem the Attorney General's office reports doctors having is not understanding how to go through the certification system in order to sign up. They're going to great lengths to make that clearer for doctors, and it's all on their website now. So I just want to remind you of that. And maybe I should step back and let you know that Consumer Watchdog is in support of SB 482. And just reiterate that this is a simple duty to check a database that places absolutely no mandate on a doctor's decision as to how to prescribe. It simply provides that extra information. And although we are fine with the amendments that have created these exemptions, for example, hospice care, sure, we don't think anyone in hospice we need to worry about addiction. At the same time, there's no actual burden for a physician who is prescribing in hospice care to check the database. So similar with all of these exemptions, we think they're okay, but they're not really necessary. And throwing up opposition simply because the CMA doesn't like the wording, I think is really just a red herring that hides the larger issue of them being opposed to mandatory use in general. So we urge you to hold on to your support position.
Thank you.
Good morning. Julie D'Angelo Felmuth from the Center for Public Interest Law, and I will fill out a speaker slip. I apologize. I just wanted to get up and reiterate CPIL's support for this bill. We supported it before it was amended to address all of CMA's concerns, and you supported it as well before it was amended to address all of CMA's concerns. It's now been amended. These exemptions cover all the necessary situations. And I would point out that in your analysis, many other states have required a check with a state's prescription drug monitoring program. And in those states, and also the federal government recommends this as well, in those states that have required a check with the PDMP, doctor shopping has dropped precipitously. That's what we want in California. We urge you to retain your support position on this bill. Thank you.
All right, thank you very much. Comments?
Yeah, I think I do understand CMA's concerns, especially the first two. That is about outpatient surgery centers not included, and the other one is about nurses giving medication under doctor's orders in the hospitals or outpatient surgery settings or any other facilities. So, but I am a strong supporter of PDMPs. Actually, that's one of, as I mentioned, one of our biggest problem is prescription drug overdose. So the only way we can get there is we got a system. Important thing is that works. And I do hear about cures issues. I think it's Cures 2.0 significantly got better compared to 1.0, which was a complete disaster. I can say that because so many people came and complained to me. But the answer is not to go there. That's not the answer. We have to improve it so that we can have a decent PDMP with appropriate exemptions in a facility settings so that we can still have that monitoring program.
All right, thank you. Is there a motion?
No, I have comments.
Oh, I'm sorry, Dr. Lewis, I
You have
apologize.
comments.
And then Dr. Yip and Dr.
Oh,
Bishop.
yeah.
Dr. Lewis first, Dr. Yip, then Dr. Bishop.
A comment, question for Jennifer. The first exemption talks about when the database is inaccessible or the internet is not operational. Do you know if it's an individual issue at that particular office because Wi-Fi and internet goes down, or is it a DOJ will make an announcement that as of this time the internet is now not operational?
It's probably both, because this language is directly taken out from the bill. So if we were looking at it, and if we were going to look at someone complaining like, okay, this doctor didn't check cures, we would look at it, I think, Kim, correct me if I'm wrong, that it would be either or. If either DOJ didn't make the system available or the doctor had difficulty.
Yeah, because that's the concern that I hear is that sometimes the doctor just can't get on. It happens in remote areas, and I just want to make sure that that is.
And I think
covered.
the purpose of these exemptions is to address those concerns like the one you just raised, and they have been
Okay.
raised by others, yeah.
Okay, good, thank you.
Do you have any other questions, Doctor? Are you good?
Not me, I'm
All
fine.
right. Dr. Yip?
I think the idea is good, but technically it's also difficult. I prescribe medicine because a lot of patients kidney stones, etc. And now we're bombarded with electronic medical record, discharge, prescription, medication reconciliation. I think we also need to share the burden by the hospitals and outpatient surgery center. When they give us a printout of the medication, maybe they should be required to print a history of those prescribed medicine that patients have, so that we don't have access to the computer and access to the data and access to the information that should be made ready, handy for the physician to use.
Dr. Bishop?
And I express some ignorance here because as an anesthesiologist, I always prescribe all the drugs that I give directly. I just give everything directly. Can an MA or a nurse or anybody access the Cure system, or can it only be the physician?
It's anybody who's authorized to prescribe or administer. So yes, if they have a DEA and they're licensed, they can access care.
'Cause
So
this
both
can-
nurse practitioner and PA can both do that.
And that, we discussed this at the PA board, and this can be a real problem in a busy practice, particularly ED, where they have to stop and do the search. I think it should be done, but I would like to see some amendment that would allow a designated individual, perhaps in the ED, a designated RN or some legislative regulation that allow that to happen, because you don't want to slow down things. You want someone to be checking it, but that's really not the PA or physician's job to be a database checker. They need to take care of the patient.
So right now you can have a delegate. So they fixed when Cures 2.0 went in, I could have, my MA, go ahead, get into the system, request it, and then the doctor just prints it out.
Excellent.
So it's already
Thank you. That
a
resolves
delegate,
my
they call it.
concern.
Dr. Hawkins?
Clarify again, this would be evaluated on an annual basis, the fact that the physician or other person did not access cures appropriately?
Dr. Hawkins, you're asking when the doctor would have to do it?
Yeah, on an annual basis to check.
Annual.
Okay, so the doctor didn't do it 3 times. When would the doctor be advised that you're out of compliance with checking for?
They would have to look at their records. So if they had a person that came to you, you have to do it on the first time. So the first time the patient comes to you, you would check it. And then on an annual basis, you'd have to make sure you know in your records to check this again, and then annual basis.
Okay,
It'd
I
be up to
understand.
the physician to monitor it. And then if we got a complaint, we'd look at the medical records to see if that happened.
Understood, thank you.
All right. Dr. Kraus?
I speak in favor of support, and I'm sympathetic to the points made by Ms. Chung, but I think there will always be a need for some exemption, and we'll have to learn as we go along what it is that needs to be exempted, but I'm disappointed to imagine that we're putting this effort into creating a cure system, but we're putting roadblocks up to requiring its use. It doesn't make much sense to have cures unless we're going to require that it be used. So I would like this bill to pass and for us to support it.
Thank you. Are there additional comments?
Yeah, just to give a clear answer is that you can assign one of your people to access the cures database as a physician, but the answer or the information goes back to the physician. It doesn't go to the person you assigned, so that means that's why it's HIPAA protected. So so that is the important issue, and I would support with the couple amendments. Because generally I support, but I think as we do these things, we got to make sure that it doesn't make, especially in the hospital, life really miserable for our surgery centers. So with that, I think I strongly support.
One more, David, if I may.
Sure.
I just, Jennifer, if you could just take this back to the authors, perhaps, that we do have concerns, that they are aware and cognizant of the potential delays it can do in provision of medical care in busy practices, such especially the ED, that there's some provisions made so that this does not interfere with that, because it does inhibit access to medical care if you're slowing things down.
I mean, we have been working with the author's office, so I think they'd be totally open to, it sounds like it's just a couple of technical amendments, like a licensed or accredited healthcare facility, right? That would take care of the outpatient setting amendment, and then just kind of making some tweaks to that wording about the person actually administering it. I think that they would be totally open to that. I mean, I think we could still support and then provide that technical assistance, but it's up to the board.
That's a good idea. I like the support with the technical assistance, if that's the pleasure of the board. Is that, Dr. Kraus, would that be your motion?
Yes.
All right, is there a second?
Second.
Second, thank you. Is there additional comment from the members? Looking to my left, my right. Thank you. Are there any comments from the audience? Seeing none, are there any comments from the phone?
No
Ms.
comments over the
Tuve?
phone?
No comments from the phone? I'm sorry, Dr. Levine?
Yeah, in the spirit of technical
Yes.
amendments, the definition of inaccessible, I think will be important, and one of the things that makes the system inaccessible is very delayed response times. One of the challenges with Cures Cures 1 was sometimes very long response times in terms of getting the information, and so just ensuring that we know what inaccessible means, because I think that came straight from the language of the bill.
Yeah. All right, thank you. Okay, well, we need to call the roll. Ms. Tuve, can you please call the roll?
Dr. Bolot?
Aye.
Dr. Bishop?
Aye.
Judge Feinstein? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines?
Aye.
Ms. Sutton Wills?
Yes.
Mr. Warmoth? Ms. Wright?
Aye.
Dr. Yip?
Aye.
Mr. Serrano Sewell?
Aye, the motion carries. The next item will be handled by Ms. Kirkmeyer.
The next bill is SB 1174, McGuire. This would add to the board's priorities acts of clearly excessive prescribing, furnishing, or administering psychotropic medications to a minor without a good faith prior examination of the patient and medical reason therefore. Although the board already has excessive prescribing of controlled substances in its priorities, many psychotropic medications are not controlled substances, so they would not be covered in the board's existing priorities. This bill would require the Department of Healthcare Services, in collaboration with the Department of Social Services, to provide quarterly data to the board that includes, but is not limited to, the child welfare, psychotropic medication measures, and the health care effectiveness data and information set measures related to psychotropic medications. This bill would specify that the data provided to the board shall include a breakdown by population as specified. This bill would require the board to review the data provided by the Department of Healthcare Services and Social Services on a quarterly basis to determine if any potential violations of law or excessive prescribing of psychotropic medications inconsistent with the standard of care exist, and, if warranted, conduct an investigation. This bill would require the board to take disciplinary action as appropriate. Lastly, this bill would require the board to provide a quarterly report on the results of the data analysis to the legislature, the Department of Healthcare Services, and Social Services. Anecdotally, the board does not receive complaints regarding overprescribing of psychotropic medications to foster children. The data will be required to be submitted to the board pursuant to this bill will ensure that the board can review prescribing data on an ongoing basis to help identify physicians who may be inappropriately prescribing. The data the board has received under the existing data use agreement is only a snapshot in time for a 6-month period in 2014. Any information that can help the board identify inappropriate prescribing can be utilized as a tool for the board to use in its complaint and investigation process. However, once a possible inappropriate prescriber is identified, the board still has to go through our normal complaint process and investigation process. Board staff is suggesting the board support this bill as it will further the board's mission of consumer protection for a very vulnerable population. However, amendments are needed to ensure that the board will continue to receive the same data requested under the current data use agreement, including the associated physician information and de-identified patient information. The board would also need to receive the additional data recently requested by the board's expert pediatric psychiatrist, and that was in my report from yesterday, the written report, yes. So board staff is working closely with the author's office on the bill and suggests that the board take a support if amended position. With that, can I have a motion?
So moved.
Second.
It's been moved and seconded. Members, are there any questions or comments on the motion?
I think with those amendments, we're fine, but my issue with this doesn't address is that there's a huge problem with these institutions with social services. That's where the problem is. We are addressing peripheral issues rather than the real issue of getting some decent support for these kids with mental health issues. So that's where I hope that they would do something with that rather than just address only these peripheral issues.
So, Dr. Gunnett, if there were 3 bills that passed last year that is improving that process, I don't think we took a support on them or we were neutral on them because they didn't really impact the board. This is the first one that impacts the board, but those are all there to help. Senator McGuire, we've met with him numerous times. This is one of his main goals, and he understands that we're one piece in a larger wheel. And then I believe that like I said yesterday, with that Bureau of State Audits report coming out in the summer, I think that will also make some necessary changes to the system or recommend them.
All right, thank you. Are there any? Oh, yes, Judge.
This is an area that I have spent a couple decades working on in terms of children in foster care and that are dependents or wards of the court. And most of the children to whom this law would apply would fall into one of those categories. And I was a little bit perplexed, and I can't put my hands on my notes from your report yesterday right now, but I'm a bit perplexed because this is a county responsibility. And when I read that there, was concern that somehow there was going to be, I've never needed a microphone. State DSS was going to come along and provide information, the weight of a child, how often something is renewed, that's not the issue. That's not the problem. And, you know, the issue is we have children in foster care all over the state. They have moved away from more urban areas because of the cost. Social workers are required to put eyes on a child every 30 days. And in many areas, you don't have licensed, board-certified child psychiatrists who are prescribing these medications. The important thing is to have what is done reviewed by somebody who is an expert and can assess this. I know the problem well, and I just don't know that this solves the problem. You know, if a child is in one of the remaining mental health care facilities for children, and they're falling by the wayside because of cutbacks in funding. There is no mental health care, or very little, for children in the state. That may be one thing, but they're a different classification of child than as a child who is in a foster home somewhere in a remote area. And I don't know that I can put my finger on it, but there's something about this that isn't sitting right with me, and I really would like to hear comments from people that maybe can help me put my finger on what I'm uncomfortable with.
So Judge Feinstein, I think the problem is you're absolutely right. This does not solve the problem. This bill is.
Well, I want to solve the problem.
One very small portion of the larger problem, kind of going to what Dr. Gonadev has said. One thing we've tried to do is encourage individuals in the whole process, because we can get the data, but it is truly like identifying a needle in a haystack to some degree with the data that we get. So this at least makes sure that we get the data and then we can review it. We've talked time and time again to all of the entities involved, including the Senator's office and everyone, that really at the point that would make the biggest impact is if the individuals who see these individuals, your social workers, your county health care nurses, all of the individuals involved in the process, if they see something that appears to be inappropriate prescribing, which is where the board falls in, because not having enough providers and everything, that's a whole nother issue outside of the board. But if they do see an individual who is inappropriately prescribing, that they would make a report to the medical board, and that's what we continue to kind of go back on the individuals in the system to try to tell them, please make a complaint to the board. We're involved, as you know, in a lot of the quality improvement projects with DHCS and DSS on it, but at the end of the day, I understand your concerns, because it's not going to solve the problem. It is going to put some information in the hands of the medical board.
My question, though, to anybody is, why doesn't this responsibility fall to the counties that have all the information the board's expert says was lacking? They have all that information. It's in every court file for every foster child in the state. And why are we going through all this with these, DSS and these other state agencies that may or may not have it when we know where it is?
So what we're hearing, I know Dr. Levine has something too, but from what we're hearing, the only place really where all of the information is available to be pulled from, so where we can actually gather some data that's electronically that we can get the information, is from the Department of Healthcare Services, because they do Medi-Cal. So that all of the prescriptions and everything have to be paid, all of the treatment, so that's why they're involved. And then the Department of Social Services has the information on the children. And so that's why those two entities, but but you're right, what's gonna happen is once we do look at it, we're gonna have to go back to the county level to be able to get that information on the medical records and everything of the child. And again, we're not to the point even where we know if the data is helpful because we haven't got the most recent information we've requested to see if our psychiatrist is gonna be able to identify those issues.
Sharon?
As I read this isn't just about children in foster care. This is about all children in Medi-Cal, whether it's Medi-Cal fee-for-service or Medi-Cal managed care. So that is a very large population. And as I understand it, this is de-identified data. Is that correct? So the only identification is the prescriber. So from de-identified information about a very large number of children, talk about a needle in a haystack. I mean, I'm trying to identify appropriate versus inappropriate prescribing of these meds. I think you're going to drown in data in terms of, and, you know, I'm quite confused about what I believe is a correct problem identification, but this is a very circuitous path to trying to solve even a little bit of it. So what's the recommendation on this?
Support if amended, I believe. No, support.
If amended.
Support if amended.
We want to drill down on that. What's in the bill now is, like you said, a really wide range of data. We want to incorporate the stuff that's in our DUA, which is
DUA?
the data usage agreement that we have with DHCS and DSS now, which will kind of narrow that down a little bit. And that's what we're kind of going off now, and that will ensure that we get it on a regular basis, that we don't have to go through this DUA process every time. We want to get more information and that we can have that information to look through.
Is there a sunset in this bill?
There's not
Or-
a sunset, no.
I mean,
it's-
it seems to me, given I think the somewhat confused approach to this, it would be worth, as one of the amendments, asking that there be an evaluation of the utility of the data and the degree to which it has actually been able to increase the appropriate care of children in the Medi-Cal program.
Well, we would actually have to provide reports to the legislature. So if we found, let's say, that we got all that data and it's not helpful and we can't, that would be in our report to the, to the report to the legislature. So it's like we're constantly going to be checking in and like, here's the data we got, kind of here's how many actions we could take out of it, or it's here's the data we got. It's not enough to take any actions because we need more or we don't have enough, or so that would be included
Or
in
it's
those.
the wrong data.
I think what a sunset does is it gives it priority, sunsets it, and it requires like an in-depth assessment if the policy's objectives are being met.
Yeah. Mm-hmm.
That's how I,
Yeah, and
part of
otherwise,
what it
it's
says.
very hard to unring a bell. It's very.
you be okay with that? I think staff would be okay with including the support if amended, the sunset suggestion from Dr. Levine.
Okay.
Okay. So there's been a motion and a second. Thank you. Are there additional comments from the members? Seeing none. Are there comments from the audience? Please.
Carrie Sparrowon. So if I'm understanding this right, the data that you're going to get on the prescribing practices of specific physicians to Medi-Cal children, what I'm wondering is that in rural areas, there may be only one physician that can do the prescribing, and then is that going to impact them in such a way that now they're not going to be willing to see these children anymore? And I think that no doctor wants to be investigated by the board. And so I'm just throwing that there to get you to think about it.
Thank you. Are there additional comments from the public? Ms. Balber?
Hello again, Carmen Balber, Consumer Watchdog. Consumer Watchdog supports this legislation, and you're absolutely right, it doesn't solve the whole problem by any means. The legislature passed 3 bills last year, creating much more information, much more oversight at the county and the state level, including public health nurses. They're trying to fund some of that, which wasn't completely funded by the legislature last year. This piece goes specifically to physician accountability. This isn't going to stop the prescribing while it's happening, because the board is going to have to go through data that's past data. This is going to go towards physician accountability if all of these other measures that are going into place don't help. And I think it's unrealistic to expect the counties to go through this data and then identify the doctors they think are overprescribing and then report them to the medical board in order for the medical board to take action. The medical board is already going through data, I think commendably, from cures to identify overprescribers of opiates. And this gives the board the same data to do this in the Medi-Cal world with psychotropics that no one else is going to have the same capacity to do. And I think that's why this piece, which doesn't solve everything, is really important for the board to have.
Okay, thank you. Are there additional comments from the audience? Seeing none, are there any comments from the phone on SB 1174?
No comments over the phone?
All right, thank you. Ms. Tuve, please call the roll. This is support if amended.
Dr. Bolat?
Aye.
Dr. Bishop?
Aye.
Judge Feinstein?
Abstain.
Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Yes.
Ms. Lawson?
Aye.
Dr. Levine?
Abstain.
Dr. Lewis? Ms. Pines?
Aye.
Ms. Sutton Wills?
Yes.
Mr. Warmoth?
Aye.
Ms. Wright?
Aye.
Dr. Yip?
Aye.
Mr. Serrano Sewell?
Aye, the motion carries.
All right, SB 1177 Galgiani. This bill would authorize the establishment of a physician insertion health and wellness program, or PHWP, within the board. The PHWP would provide early identification of and appropriate interventions to support a physician in the rehabilitation from substance abuse to ensure that the licensee remains able to practice medicine in a manner that will not endanger the public health and safety and maintain the integrity of the medical profession. The PHWP shall aid a physician with substance abuse issues impacting his or her ability to practice medicine. If the board establishes a program, it shall do the following: provide for the education of all licensed physicians and surgeons, offer assistance to a physician in identifying substance abuse problems, evaluate the extent of substance abuse problems and refer the physician to the appropriate treatment, provide for the confidential participation by a physician with substance abuse issues who is not the subject of a current investigation, and comply with the uniform standards regarding substance abusing healing arts licensees. If the board establishes a PHWP, it would be required to contract for the program's administration with a private third-party independent administering entity pursuant to the request for proposal. The administering entity would be required to have expertise and experience in the areas of substance or alcohol abuse and healing arts professionals. The administering entity would be required to identify and use a statewide treatment resource network that includes treatment and screening programs and support groups, and would be required to establish a process for evaluating the effectiveness of such programs. The administering entity would be required to provide counseling and support for the physician participant and for the family of any physician referred for treatment. The administering entity would have to make their services available to all California licensed physicians, including those who self-refer to the PHWP. The administering entity would be required to have a system for immediately reporting a physician who is terminated from the program to the board. The system would need to ensure absolute confidentiality in the communication to the board. And the administering entity could not provide this information to any other individual or entity unless authorized by the physician. And the contract entered into the board would have to have specified requirements. If the board determines the administering entity is not in compliance with the requirements of this program or contract, the board would be able to terminate that contract. This bill would require a physician, as a condition of participation in the program, to enter into an individual agreement with the PHWP and agree to pay expenses related to treatment, monitoring, laboratory tests, and other activities specified in the written agreement. This bill would specify that any agreement entered into would not be considered a disciplinary action or order by the board and shall not be disclosed if the physician did not enroll in the PHWP as a condition of probation or as a result of an action by the board, and if the physician participant is in compliance with the condition and procedures in the agreement. This bill would establish the Physician and Surgeon Health and Wellness Program account in the contingent fund of the board. Any fees collected by the board from participants shall be deposited into the account and upon appropriation by the legislature shall be available for support of the program. This bill would require the board to adopt regulations to determine the appropriate fee that a physician participating in the program shall pay. The fee is required to be set at a level sufficient to cover all costs of participating in the PHWP. This bill would allow the board, subject to an appropriation by the legislature, to use monies from the board's existing contingent fund to support the initial costs for the board to establish the program. These monies could not be used to cover costs for individuals to participate in the program. The PHWP proposed by this bill is not a diversion program. It will not divert physicians from discipline, and this is of utmost importance for consumer protection. The board will not be running this program. It will be run by a private, third-party, independent administering entity that will be selected pursuant to the request for proposals process. This bill would require the PHWP to comply with the uniform standards and would require any physician participant to terminate or withdraw from the PHWP to be reported to the board. These are both very important elements for consumer protection. This bill would also allow for communication to the board for those physicians ordered to the PHWP as a condition of probation. This is also important for consumer protection. Currently, this bill states that if physician participants under board investigation are not allowed confidential participation. However, participants should be provided confidentiality unless they are on probation, or they terminate or withdraw from the program, or they are subject to disclosure pursuant to the uniform standards. As you may remember, that the board adopted elements, and after many back and forth and amendments, staff does believe that this bill now complies with all of the elements adopted by the board. And I feel that we can work with the author on those tweaks, several tweaks in the bill. So board staff that suggested the board support this bill.
Thank you, Jennifer. The elements that you're referencing was at the board's October meeting.
Yeah, and they're actually in your packets if you want to take a look.
Yeah, thank you.
Yeah.
Which there was a robust discussion and sort of a statement of policy. The author heard that statement of policy and subsequently amended her legislation to include those elements. So hence the support.
Yeah, and I would like to say too, Senate BMP was very supportive of the board-approved elements, and they really helped work, kind of as a liaison to get those amendments in place.
All right. Are there any comments from Julie, did you want to comment on this? And then we'll take a board comment and a motion.
Good morning. Julie D'Angelo Felmuth from the Center for Public Interest Law. I served as this board's enforcement monitor from 2003 to 2005, and I was required to audit the board's former diversion program for substance abusing doctors, which existed for 27 years. My 2004 audit was the fourth of 5 performance audits that program failed. Shortly after the 5th failed audit, this board voted unanimously to abolish that program effective June of 2008. We oppose this bill for a number of reasons, and I only have time to discuss a few of them with you. This is your PowerPoint. This is the elements that you approved at your October 2015 meeting. The most important element to you is absolute compliance with the uniform standards regarding substance abusing healthcare practitioners, as is required by law. In one part of this bill, it says any new program created will comply with the uniform standards. But in other parts of the bill, the bill sets forth standards and requirements that are not consistent with the uniform standards, nor are they consistent with the regulations implementing the uniform standards that you sat here and spent 2.5 years drafting. For example, on page 6 of the bill, it says the vendor running the program has to have a system for immediately reporting a physician who withdraws or is terminated from the program to the board. That is not consistent with the uniform standards, which requires immediate reporting within 1 business day of any and all major violations of the contract that the participant signs. So which controls? The bill or the uniform standards? The bill or your regulations, which, by the way, would be trumped by this bill. There are several other places where the bill conflicts with the uniform standards, including the annual report requirement, the periodic audit requirement, and the absolute confidentiality requirements. The uniform standards are mandatory. You have demanded compliance with them. You should have zero tolerance for any ambiguity in the drafting of this bill, and we think there is significant ambiguity. Another reason we oppose this bill is because it unacceptably handcuffs your enforcement program. Let's say you order a doctor to participate in the program as a condition of probation. Let's say that doctor fails a drug test. Under this bill, the program might inform your enforcement program that the doctor failed the drug test, but the board's enforcement program would not be permitted to use the evidence of that failed drug test in a petition to revoke probation or other disciplinary action. That is unacceptable, and it must be changed. We'd like a couple of additions. We believe that if this board chooses to create a new program, this board should take ownership of it. This board should be required to establish a standing committee of board members to meet quarterly, review data in public, review data that's submitted by the vendor on intakes, relapses, and terminations, sufficient to enable that committee to determine whether the program is complying with the uniform standards. You also know that I need to stop now. We urge this board to seek amendments to this bill consistent with what you insisted on
Thank you.
last October. Thank you.
Are there any additional comments from the audience?
Carmen Balber again. I will echo everything that Julie said and perhaps try to say a few of the things that she didn't. One, I'd like to clarify this key provision of the uniform standards that is very unclear in the bill but is critical. The bill specifically states that the program will be required to notify the board if a physician withdraws or is terminated from the program. But of course, the uniform standards requires a program to report to you any failure to comply, which includes a failed drug test. And this is one of the key inconsistencies that we think the board needs to be absolute that the bill corrects, because if even the board is not notified of a failed drug test, the program is not working. I think the history, this stain of such a failed diversion program in the past at the medical board gives you more reason that you have to go above and beyond to be certain that you don't recreate the failures of the past. And I think that's why the board being absolutely clear that the uniform standards and the other standards that you've set out are met is so critical. So simply supporting this and saying we hope everything's cleared up is not enough. I think you need to be very specific on that. And I think I would just point to you 3 doctors that the board recently either considered their probation or disciplined that are key examples of why the medical board really needs to rethink this program. One, on yesterday, you looked at the case of Dr. Vucinic, who had a history of drug and alcohol abuse, including 3 DUIs and a meth arrest, cycled in and out of the old diversion program and in and out of drug treatment for over a decade. I'm presuming after yesterday's debates that you will place him on probation. Dr. Nathan Kemmerly, who recently, a few years ago, got his license reinstated after being the state's top prescriber of amphetamines, second largest prescriber of opiates, and a meth addict. And Dr. Cosgrove, who lost his license in 2008, and you just renewed it, after assaulting and having a sexual relationship with 3 of his patients. Each one of these doctors is not only an example of why the board must insist on notification of a failed drug test, we're talking about 3 former meth users, but also why the board should be requiring that patients also be notified in the case of a failed drug test. And I think this is really critical because not a single one of the patients of each one of these doctors wants to be in the dark that they're on probation, number one, or if they are found to have failed a drug test after such long histories of abuse and other problems. So we would urge you to also add to your recommendation, as we did before.
Thank you.
Notifying
Are there any
patients.
additional comments from the public? Yes, ma'am.
Hello, my name is Michelle Montserrat Ramos. I'm here on behalf of Consumers Union Safe Patient Project. Regarding SB 1177, we oppose this bill. You may wonder why I care about substance abusing physicians. There are new members here who may not be aware that have come before this board for the past 8 years, pleading with you to remember that your mission is to license doctors and to protect consumers. This issue is important to me because it's personal. My fiance, Lloyd Montserrat, died in a Los Angeles hospital with no cause given for his death. He was only 36 years old. I hired a pathologist for a private autopsy. The results revealed that Lloyd died from surgical mistakes, untreated infection, and sepsis. The coroner confirmed the results. Upon further investigation, I learned that Lloyd's doctor had a long arrest record, including felony possession of crack cocaine and prostitution. In reviewing the testimony from the arresting officers, it showed in Lloyd's doctor's actions that he had no concern for his own personal safety and well-being. So how could he have any concern for Lloyd or his other patients? Yesterday, I listened to the intros of the new board members. Yesterday, the fine comments of your public service. Well, Lloyd's life was tragically taken from him, but he was dedicated to public service as well. He was the vote director for the DCCC, a director at NALEO, a political consultant, a chief of staff for the city of LA, to name a few, as well as organizing nurses for SEIU Local 660. He deserved to live. His life was cut short because he had no right to know that his doctor was a substance abusing physician. We believe this bill is unnecessary. There is no need to create a program that may undermine the oversight responsibilities of this board. There is no safe program for consumers that allows for confidentiality of any program. If doctors have the right to engage in substance abuse, then we as patients have the right to know. Lloyd had the right to know, and so since you took that right away from him, he's now dead. The bill says that it will comply with the uniform standards, but differs from the uniform standards. At this point, we agree with CPIL. You should have zero tolerance with any modifications from the uniform standards that you place in the regulations. We also support CPIL's request that the board create a standing committee of board members, both public and physicians, to have oversight of a program and ensure the uniform standards are met. A committee that meets in a public setting and ensures that the public is kept informed and that the legislature is kept informed. Your mission is to protect consumers, no confidential program, our lives matter, Lloyd's life mattered.
Thank you for your comments. Ms. Chung?
Yvonne Chung with the California Medical Association. We are the sponsors of this bill. We would like to support the staff recommendation for support of this bill. We've appreciated the board's assistance and willingness to work with us in terms of developing principles, working with all the stakeholders. We believe that the board has gone through a fairly exhaustive process of seeking input from all sides and coming up with principles, of which we endeavored to meet all the principles as Ms. Simoes stated in her testimony. For the newer members of the board, I want to reemphasize this is not a diversion program. In fact, there are diversion programs that exist for just about every other health profession and attorneys across the state. So this is actually providing less service than many of those programs are set up to do. What we're really trying to do is address a gap in early identification and intervention for physicians in crisis who are suffering from these issues, to hopefully help them before any harm comes to patients and provide a way for them to receive the assistance they need so that they can continue to practice safely. And again, we urge your support. Thank you very much.
Thank you. Ms. Simoes, would you care to comment?
Well, I just wanted to bring up that, like we talked about, it does state very clearly that this bill has to comply with the uniform standards, and that's been the intent when working with BMP that it does. And I believe some of the uniform standards that have been brought up that this bill may not comply with may have to do with diversion programs. And if we've stated this bill, it's not a diversion program. It doesn't divert people from enforcement. So if the board were to become aware of someone and it's through its enforcement process, we would go along with that process. And they're two parallel tracks. They would be getting, in the PHWP, but at the same time, they could be, getting enforcement actions taken. So I just wanted to make that clear that that some of those uniform standards actually have to do with diversion programs, which this bill is not a diversion program.
Thank you for that. Dr. Kraus, would you want to comment on this?
I think
You've
a
spoken
physician-
eloquently on it before.
A physician health and wellness program is vital for several reasons. Our mission is to protect patients. All those who've spoken today have spoken eloquently and from their heart about tragic loss and the need for protection of patients. My concern is that in the absence of a health and wellness program, doctors hide their feelings, hide their depression, hide their substance abuse, and patients are at greater risk. I don't know of another state in the union that doesn't have some form of a physician health and wellness program. And despite the fact that we had a failed diversion program, that should not inhibit us from moving forward. There will be flaws in every system. And this bill as it is, with your efforts, seems to be appropriate and needed. If we detect flaws as we go along, we may need to have regulations to address those. But I think that we vitally need what this bill will provide.
Thank you. Dr. Lewis?
Yes, I'd like to make a motion to adopt Senate Bill 1177 as support.
Thank you. Is there a second? Second from Dr. Kraus?
Second.
Thank you. Is there any additional comment from the members? Oh, thank you. Dr. Bishop?
I just wanted to, again, ask Ms. Simoes if she would just address, with the authors of the bill, these concerns that have been brought up by the other members of the public here, to ensure that we are complying with all the uniform standards as to the best of our ability as we go forward.
Yeah, we have worked very closely with the authors and Senate BMP even more so, and they are actually working on amendments right now to address the subject to investigation language and other technical kind of concerns. So I'm certain that they will address any other kind of technical issues we have.
Thank you. Michelle?
Yeah, I just wanted to ask if the members here might consider a friendly amendment that we might consider the subcommittee in some way or fashion. I think that would be really important to many people, including yourselves.
My thoughts, I agree. My thoughts on that are I don't want to get before the issue. Once, assuming it's adopted and it goes through the Assembly and the Senate, lands on the governor's desk, he signs it, at that time we'll have a full and complete bill, that would be the law, and then the board should organize some, through its standing committees or a special committee, should organize some oversight of the program. Although, so I think we should state it on the record now. I don't know that it needs to be included with any legislative amendments, but I would think it would be the board's intent to do that. Dr. Lewis?
Yeah, I'd like to make a few comments as I've sat here and actually for previous board meetings about this topic. And it's not going to be as eloquent as Dr. Kraus, but, you know, our primary goal is patient protection. But, you know, addicted people, physicians in all walks of life, deserve rehabilitation. They're not bad people. And sometimes what I hear is addicted physicians are bad physicians. They're going to go out there and do harm. People deserve a chance to rehabilitate. And I think that's what this bill allows us to do for those individuals who want to seek help, but have up to now been afraid to come out and say, I need help. So those are my comments.
Thank you.
I have a lingering question on the bill, and that was with regard to confidentiality, where a physician may have self-referred, even though that physician is on probation. Does that physician then not have confidentiality?
If they are on probation and they were ordered to a program as a term and condition of their probation?
No, if they self-referred to the program.
So if they self-referred to the program, we will, and we also know about it, you're saying we also have a complaint. we would put it through the process. We would also order them into probation, so they can't just drop out on their own or anything. So usually when we had a program, even though it was a diversion program, but when we had a program, even if an individual was in as part of that board probationary order, we would order the person in, so then it would be public to, everybody would know that that person was in that program as part of that probationary order. I don't see that being any different now, the way we would process those disciplinary actions.
So to the extent that a physician was not ordered in any way to participate here and put themselves into the program, it would not be confidential?
So it would be confidential unless there were restrictions put upon that doctor. So one of the terms, one of the uniform standards, and I can't think of which one it is, but one of them states that if an individual has any restrictions, even if they're a self-referral, if they have any restrictions, and that would be like, maybe they can only practice 20 hours a week, I can't think of another example, but something like that, then that actually has to be listed. The board has to put that on the website, but we can't say that it's because the individual is in a substance abuse or in a physician assistance program or PHP. So it would have to be listed. We'd have to put the information on the web page, but it wouldn't say it's because they're in a physician health program. Does that make sense?
Does that help?
So, but if they don't have any restrictions and they're in the program and they're complying and everything, then that wouldn't be public knowledge if it's a self-referral.
Thank you. Thank you for that question. Are there additional comments or questions from the members? There's a motion to adopt. Ms. Toof, can you please call the roll?
Dr. Bolat? Aye. Dr. Bishop? Aye. Judge Feinstein?
Oh, no, I apologize. Ms. Toof, just one moment. We had public comment from the audience, and I didn't take public comment from the phone. Is there any comments from the phone?
We have no comments at this time.
All right, I apologize for that, colleagues. Ms. Toof, can you start from the top?
Absolutely. Dr. Bolat?
Aye.
Dr. Bishop? Aye. Judge Feinstein?
Aye.
Dr. Ganadev?
Aye.
Dr. Hawkins?
Just pass for now.
Dr. Kraus?
Yes.
Ms. Lawson?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines?
Aye.
Ms. Sutton Wills?
Yes?
Mr. Warmoth? Ms. Wright?
Aye.
Dr. Yip? Mr. Serrano Sewell?
Aye, the motion carries. Thank you. Colleagues, we have 3 more bills, I believe, and so if we can get through these, then we will take a break, if that's all right. Let's get through this section of the agenda.
Okay, SB 1189 would require a forensic autopsy to be considered the practice of medicine. It would expressly state that forensic autopsies can only be conducted by a licensed physician and surgeon. This bill would require that the results of an autopsy may only be determined by a licensed physician and surgeon.
Ms. Simoes?
Yeah.
Sorry to interrupt you.
It's okay.
Dr. Hawkins has
Oh, sorry.
joined us. Dr. Hawkins, the motion on 1177 passed. That was the physician wellness. Do you want to record your vote?
Yes.
Yes, thank you. Please continue.
Okay, and this bill would define a forensic autopsy as an examination of a body of a decedent to generate medical evidence for which the cause and manner of death is determined, and there's, along with other provisions included in this bill. The Ventura County District Attorney's Office published a report in February 2016, and in this report, it reviews the investigation conducted on Ventura County's former medical examiner and discusses the obstacles faced by the DA's office in pursuing criminal action. In the report, it brings up several gray areas of law related to autopsies and who can perform them. The report states that there is no California law that defines an autopsy, and there is no statute that clearly defines that the performance of an autopsy is a practice of medicine. And the report also states there is a need for legislation to clarify these issues. In reading the Ventura County DA report and in discussions with Senator Jackson's office, board staff believes there are gray areas in the law related to autopsies being the practice of medicine and who can perform autopsies. Board staff believes it should be made clear in law that autopsies are the practice of medicine and can only be performed by licensed physicians and surgeons. This clarification will assist the board in its enforcement actions and further the board's mission of consumer protection. Board staff is suggesting a support position.
Thank you. Is there a motion?
Make a motion to support Senate Bill 1189 as support.
Thank you.
Second.
There's been a motion and a second. Are there any comments or questions from the members? Seeing none, are there any comments from the public? No comments? Oh, I'm sorry, sir. You had a speaker's card, and welcome.
Sorry, good morning. Michael Schwartz, representing the Ventura County District Attorney's Office. The report that was referenced by staff, it's 50 pages, it's on our website, and it was based on a complaint we had that a administrator was opening up bodies and manipulating organs, taking samples. In one case, he was, there was some evidence that he was looking for the primary source of cancer, even though he had no medical training, although that one was disputed. Meanwhile, the medical examiner was on a cruise and was communicating with this administrator via email. And then when the medical examiner returned to the country, he signed off on death certificates for bodies that he'd never seen. The word autopsy comes from Greek, which means to see with your own eyes. And I think the law should reflect that autopsy should be conducted by doctors and not by office staff. It seems like a no-brainer to me. So I think SB 1189 is a big step forward to say that what an autopsy is and who can perform it. I should note that we are seeking some amendments, particularly regarding the presence of prosecutors and detectives and investigators during the autopsy. The California State Sheriff's Association is currently opposing the bill because it's important to them that they be permitted to have someone in the autopsy suite. We often have to make filing decisions on homicide cases within 48 hours if the person's in custody before a report will be prepared. So it's important to us that we be permitted to be in the room. I don't think that's this board's problem. I think this board it's a medical issue, and so I think this board should support it.
Thank you.
Thank you.
Please send our regards to District Attorney Totten.
Will do. Thank you.
Appreciate it. Thank you for being with us. Is there any addition? Yes,
A comment,
Please.
Mr. President. Ventura County is not the only county, I think, that has suffered adversely from situations like this. And sheriffs are not trained in medicine, not qualified. Coroners are not medical professionals also. And thank you. In my professional career, I saw some significant cases be severely compromised because sheriff's departments who had to employ physicians to conduct autopsies didn't want to expend the funds, didn't have the funds, and didn't want to hire medically licensed forensic pathologists to conduct these autopsies. So not only to ensure good prosecutions, but just the ethical overriding of how we should conduct our legal system, I think really to the extent the medical board is involved in this, really would call that we support this bill.
thank you. Are there additional comments from the members?
Actually, a question I strongly support. Why is Hospital Association opposing this one? I can understand the Sheriff's Department, why they are, but Hospital Association?
I'm not sure. I can check in on that, though, and let you know.
Are there additional comments from the members? Seeing, did I do public comment on this? No, I haven't. Are there any comments from the audience? I did. We heard from the district attorney. Is there any comments from the phone?
No comments over the phone.
All right, thank you. Ms. Toof, can you please call the roll?
Dr. Bolat? Aye. Dr. Bishop? Aye. Judge Feinstein?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins? Yes. Dr. Kraus?
Yes.
Ms. Lawson?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines?
Aye.
Ms. Sutton Wills?
Yes.
Mr. Warmoth? Aye. Ms. Wright? Dr. Yip? Mr. Serrano Sewell?
Aye, the motion carries. Two more items.
Okay, the next one, SB 1261 Stone. You should have a handout because since this packet went out, this bill was substantially amended. So Before, it was a whole lot more, but now it just allows out-of-state physicians who are licensed in California to have their license and renewal fees waived if they certify to the board that the sole purpose of their license is to provide voluntary unpaid service. Right now, these fees are waived if they're a resident of California. This bill would just expand that to out-of-state physicians that are licensed in California. And board staff is suggesting the board take a neutral position on this bill.
Okay. Are there any questions or comments from the members? Looking to my right, my left. Is there a motion?
I so moved on Senate Bill 1261 to a neutral position.
All right, is there a second?
Second.
Second, thank you. Are there any comments from the audience? Seeing no comments, is there any comments from the phone?
No comments over the phone?
All right, thank you. Ms. Tuve, please call the roll.
Dr. Bolat?
Aye.
Dr. Bishop?
Aye.
Judge Feinstein?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines?
Aye.
Ms. Sutton Wills?
Yes.
Mr. Wormuth?
Aye.
Ms. Wright? Dr. Yip? David Serrano Sewell.
Aye, motion carries. Next item.
Last bill. Okay, SB 1471, Hernandez. Under current law, revenue from fines and penalties levied on health plans is deposited in the Managed Care Administrative Fines and Penalties Fund. Existing law requires fines and penalties collected up to $1 million to be deposited into the medically underserved account for physicians and the Health Professions Education Foundation for purposes of funding the Stephen M. Thompson Loan Repayment Program. Existing law requires any amount over the $1 million to be transferred to the Major Risk Medical Insurance Fund to be used upon appropriation by the legislature. This bill would require, beginning January 1st, 2017, and annually thereafter, any amount over the first $2 million, including accrued interest, to be transferred into the Health Professions Education Foundation for the Stephen M. Thompson Loan Repayment Program. This bill would allow one half of these monies to be prioritized to fund repayment of loans for those physicians who are trained in and practice psychiatry as specified. This bill would also make other conforming changes and delete references to inoperative programs. This bill would provide much-needed funding for the Stephen M. Thompson Loan Repayment Program to assist with loan repayment for physicians who agree to practice in medically underserved areas of the state, as well as prioritize new funds for those who are trained in and practice psychiatry. This bill would promote the board's mission of access to care, and board staff suggests the board take a support position on this bill.
Thank you. Are there any questions or comments from the members? Seeing,
Why was, just a question, why was the $2 million number picked?
Well, so right now, the first $1 million is for a certain thing, right? That's for the Stephen Thompson. The second $1 million is for the, another program. So they're saying basically if you collect anything over that, then it should go to the Health Professions Education Foundation for the Stephen M. Thompson. And because of the way the priority runs in psychiatry now, it's like only 20% of that first $1 million can be used for psychiatry and a whole bunch of other kind of specialties. They're kind of prioritizing psychiatry in that anything over $2 million. So it's just basically specifying if funds are collected over that, where they kind of go, and earmarking them for the Stephen M. Thompson program.
all right, thank you. Are there additional comments or questions? Seeing none, is there a motion?
I move that we support Senate Bill 1471.
Thank you. There's been a motion and a second. Are there?
Second.
Thank you. Is there any comments from the audience? Any comments from the phone?
No comments over the phone?
All right. Ms. Tuve, please call the roll.
Dr. Bolat?
Aye.
Dr. Bishop? Aye. Judge Feinstein?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Go through.
Aye.
Ms. Pines? Aye. Ms. Sutton Wills?
Yes.
Mr. Wormuth?
Aye.
Ms. Wright? Dr. Yip? Mr. Serrano Sewell.
Aye. Motion carries. I think we can be fast with 11B, 15B and C.
I don't think we have anything for 15B, actually. I don't think
All
we
right.
should have included that, so that
Okay.
one's done.
All right. Great work.
And 15C is just the status of regulatory actions, and so that matrix is in your board packets under tab 15. So I'm here to answer any questions board members may have on that matrix.
Seeing no questions, it is, by my watch, by my iPhone, 11:14. The board stands in recess till 11:20. Thank you. Hello, hello, hello. Thank you. The medical board is now back in session. We'll move to agenda item 16, and thank you, Jennifer Simoes, for that outstanding report. That was 2 hours. Very much appreciated. I know. Okay, we'll now move to agenda item 16, update, discussion, and possible action on recommendations from the licensing committee. Dr. Bishop.
Thank you very much. Mr. Warden yesterday made a very excellent presentation regarding minimum requirements for board-recognized accredited postgraduate training. The presentation focused on the possible need to increase the minimum requirements for postgraduate training. Since the way medical education was taught in the 1980s is very different than the way medical education is being taught today, not to mention the massive expansion in knowledge and skills necessary to be a functioning physician. Mr. Warden explained the pros and cons of increasing the minimum requirements. If the minimum requirements are increased, there is a need for a training license. He discussed in general terms what a training license would allow a resident to do, when a training license would be issued, and others. Mr. Warden will be sending out a PowerPoint presentation for review by some of the UC Associate Deans for Graduate Medical Education for input, and will provide the PowerPoint to designated institutional officers to present at a monthly ACGME Program Director meeting to obtain input for board staff to help to identify all of these issues and the lead time that may be necessary to implement any changes. Increasing the minimum requirement may eliminate the need for board staff to review international medical schools and instead use the list of medical schools in the World Directory of Medical Schools. The World Directory of Medical Schools has been developed through a partnership between the World Federation for Medical Education and the Foundation for Advancement of International Medical Education and Research. Mr. Warden also made a presentation on special faculty permits, including some historical background, how many special faculty permits have been issued since the inception of the program, and the number of current permits. Board staff sent a survey out to medical schools regarding the need and if the medical schools had any recommendations for changes that should be considered by the board. Mr. Warden presented the results of the survey. Board staff will be following up on some of these questions. Mr. Warden also made a presentation on the current special programs the board approves pursuant to the Business Code, Business and Professions Code, and California Code of Regulations sections. These include BPC 2111 Fellowship Medical School, BPC 2112 Fellowship Teaching Hospital, BPC 2113 Faculty Appointment Medical School, CCR 1327 International Medical School, Student Clinical Clerkship Rotations, Teaching Hospital. This concludes my report. Are there any questions?
Thank you for that report. Are there any questions from the members? Seeing none. Oh, Dr. Levine?
Not a question, just a comment. I want to congratulate Kurt for this excellent work. And I think, to me, there is no more important consumer protection than looking at raising the bar for getting a license to practice medicine in California. I think we are long past the point in terms of medical science, technology, and information where a single year post-medical school should be sufficient for someone to practice autonomously and independently.
Thank you. Are there additional comments or observations from Dr. Bishop's report? All right, seeing none. Thank you, Dr. Bishop and the committee, for your hard work. Are there any comments from the audience? Seeing none, are there any comments from the phone?
No comments over the phone?
Thank you. We'll now move to item 17.
Today we're here to ask for approval for the Universidad Autónoma Guadalajara School of Medicine International Program. Staff is requesting the board to recognize UAG's four-year curriculum and deem it to be in substantial compliance with requirements of Business Professionals Codes 2089, 2089.5, and California Code of Regulations, Section Title 16, Division 13, Section 1314.1. The report is on pages BRD 17 through 1 and 2. So my report's on page 1, Dr. Nuevo's report's on page 2. Unfortunately, Dr. Nuevo is not able to be here today, but however, Dr. Nuevo has, and I have both individually and collaboratively reviewed all the information that was requested at the last board meeting that UAG has since provided to the program, and we conclude that the school does meet all those requirements, and I'd like a motion.
Okay. Dr. Lewis?
Yes, I'll so move for your motion to accept the University in Guadalajara.
Second.
Second, there's been a motion and a second to the second to approve the application. Is there additional comments from the members? Yes.
How is it different from Guadalajara Medical School, which has the students are all over?
The difference is they changed their curriculum to be more like a U.S. curriculum than the standard Mexico curriculum. This is just for the international program only.
This is in English, I gather?
It's actually taught in both English and Spanish, so.
Students can rotate in third and fourth year through the U.S. hospitals?
Yes. Actually, most of the students do the rotations in this program in the U.S., so.
Similar to Caribbean model?
It's similar to that, yes.
You recall and Kirk referenced this in his report, and it's in the report, there were some specific issues and questions that this board had when we heard from the delegation from the university and your report, and you've gone back and looked into them and are comfortable in recommending its approval.
Yes, I am.
Thank you. Are there any additional comments or questions? Seeing none, are there any comments? Yes, ma'am. Oh, 17. Please, Ms. Hollingworth, thank you.
Yeah, we do have a question over the phone.
I'll get to the phone comment in one moment. We have a member of the public that wishes to speak.
Hello, my name is Marion Hollingsworth, and I'm speaking on my own and not in connection with any group. I would like to express my concern regarding the Universidad Autónoma de Guadalajara. I've been working on a list of egregious offenses by doctors in California, along with other interested parties, and we have noticed that the Universidad Autónoma de Guadalajara shows up frequently as a medical school that some of these doctors have attended, and some of the most frequently cited disciplines was for sexual misconduct. And Loma Linda was also shown up on the list, so please don't feel like I'm only singling out Guadalajara. I'd like to suggest that in order to receive recognition, the Universidad Autónoma de Guadalajara mandate a class on ethics and boundaries. This would not only protect future patients, but would also better protect the doctor's career and the reputation of this medical school. Thank you.
Thank you. Are there additional comments from the audience? No? Seeing none, are there any comments from the phone?
Go ahead, Stephen. Stephen, your line's open.
Okay, thank you. Yes, there is a comment. Yes, I have a comment. Okay, this is Stephen Borman. I've been the attorney here in California for the Universidad Autónoma de Guadalajara Escuela de Medicina, and I just wanted to take a very brief moment to let the board know how grateful we are to Kurt Warden and the staff. They've done a wonderful job through a difficult review process. They've been very fair and balanced in their approach. And I finally want to say that UAG for 40 years has provided California with Spanish-trained, Spanish-speaking, reading and writing physicians, including one of my high school and college classmates, Dan Nowinski, who's the chief of staff at the Yuba City Hospital. And we have a very strong need, obviously, for Spanish-speaking physicians, and UAG fulfills a very valuable role in that particular need. So again, I want to thank the board, and I want to thank Kurt Warden for his work and the work of his staff. Muchas gracias a todos. Thank you.
Thank you for your comments. Are there additional comments from the phone?
No further questions over the phone.
All right, thank you. No further comments from the phone. There's been a motion to approve the application in a second. If there's no additional comments from the members, Ms. Toof, can you please call the roll?
Dr. Bolat? Aye. Dr. Bishop?
Aye.
Judge Feinstein?
Aye.
Dr. Gonadev? Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines?
Aye.
Ms. Sutton Wills?
Yes.
Mr. Wormuth? Aye. Ms. Wright?
Aye.
Dr. Yip?
Aye.
Mr. Serrano Sewell?
Aye, the motion carries. Thank you, Kirk, for your work. We'll now move to agenda item 18, discussion and possible action on proposed regulations for midwife assistants, adding Title 16, Division 13, CCR sections 1379.01 through 1379.09. Ms. Webb.
Thank you. Please turn to page 18 in your books, or, I'm sorry, tab 18 in your books. I'm going to be talking about the midwife assistant regulations. And effective January 1st, 2016, SB 408, Morel, created Business and Professions Code Section 2516.5, which formally allows licensed midwives and certified nurse midwives to use midwifery assistants in their practices. Midwife assistants are unlicensed individuals who must meet specific requirements pursuant to Business and Professions Code 2069, which deals with medical assistants. And they must meet other requirements to be established by the board through the regulatory process. Board staff held an interested parties meeting to receive input and help to craft the proposed regulations. And the draft was presented to the Midwifery Advisory Council on March 10th, 2016, where additional input was received. Staff is requesting authorization from this board to initiate the rulemaking process and to formally notice the proposed language for public comment and a hearing to be set at a future board meeting. And you'll notice in the regulations that it addresses the qualifications to be a midwife assistant, who can supervise, what types of technical assistance they can provide. It also talks about training by licensed midwives, certified nurse midwives, and also schools that we anticipate will develop to fill this need, just like they've developed for medical assistants. And these mirror what is required for medical assistants in their training. And let me know if you have any questions.
Are there any questions or comments from the members? Dr. Hawkins?
Just like to know, what's the primary role of this assistant? Succinct.
It's the role that would be filled by an unlicensed, limited trained person who can be trained by the licensed midwife, certified nurse midwife, or to go through a school, who can provide support during office visits, during labor and delivery, but not take on a role that a licensed person is expected to take on. And the regulations and also the statute, Business and Professions Code 2516, lays out some of the things that they can do.
Okay. Yes.
So it's pretty similar to the kinds of things that a medical assistant can do. So it's those limited functions.
Thank you.
All right, thank you. Are there additional comments or questions from the members? I do have a speaker card, so we'll take public comment before entertaining a motion. Claudia Bergilia? Hello. Sorry if I didn't get your last name right. Good afternoon.
Good afternoon. That's fine, it's Borrelia.
Oh.
And I am a licensed midwife and certified professional midwife working at a birth center here in Los Angeles for the past year, and I work doing home birth for 15 years in the Sacramento area. I would like to come out in full support of this. What happens now is we are only allowed to use students in an approved school or other licensed midwives as our assistants. An assistant is necessary, and someone who has had enough training to be able to help with a resuscitation or drop meds or any of those support things. Our assistants always work under our supervision, and what this would allow is for midwives who don't want to train another midwife to have an assistant that isn't another licensed midwife. And then what that will do is make midwives more available to consumers.
Thank you for your comments.
Thank you.
Are there additional comments from the audience? Are there any comments from the phone?
No comments over the phone.
Okay. Is there a motion to approve the language as proposed and notice the language for public comment, for a public comment period, and then to schedule a regulatory hearing at the meeting in July? Is there a motion?
I'll make a motion to,
So moved.
move those recommendations.
Thank you. The motion's been moved. Is there a second?
Second.
Thank you. It's been motioned and second. We've heard public comment. Ms. Toof, can you please call the roll?
Dr. Bolat? Aye. Dr. Bishop? Aye. Judge Feinstein? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson?
Yes.
Dr. Levine?
Yes.
Dr. Lewis?
Aye.
Ms. Pines? Ms. Sutton Wills? Mr. Warmoth?
Aye.
Ms. Wright?
Aye.
Dr. Yip? Yes. David Serrano Sol?
Yes, the motion carries. Thank you. We'll now move to agenda item 19, update, discussion, and possible action on recommendations from the Midwifery Advisory Council meeting. Ms. Sparavon?
Thank you. Thank you for your approval of moving that regulation forward. I'd just like to say, in the interest of time, that my full report can be accessed on the Medical Board website under agenda item 19 for this meeting. And so the only thing I really want to comment on here is the action by the Midwifery Advisory Council at our last meeting, March 10th, to appoint Dr. Anne Marie Adams to the physician vacancy on the MAC. Since Dr. Haskins resigned from the MAC a number of years ago, it's been really difficult for us to find a physician who participated fully for one reason or another, and mostly I think because they weren't in the area. And so I was very excited to have Dr. Adams apply and for the MAC to approve her and recommend her to you. She's already shown interest. She comes to meetings, she's been to interested parties meetings, and she always gives very good, succinct comments that move us forward. And in addition to that, she's in a unique position to really understand the inherent issues in home birth, because she works closely with licensed midwives in the Sacramento area and also attends home births herself. The only other thing I have for you guys is to approve my list of agenda items for our August meeting. I need approval of the following items: updates on changes to the licensed midwife annual report, update on regulations for AB 1308, update on the revision of the hospital transfer form, update on midwifery-related legislation and the midwifery program, discussion and approval of appointee to the licensed midwife position, which I think Mr. Warden is going to talk to you about in a minute, and a report from the California Association of Midwives on a quality of care program that they're developing for licensed midwives in the state.
All right, thank you. Yes, can I have a motion to approve the agenda items for the next MAC meeting as requested by Ms. Sparavon?
So move.
Second.
Second. Is there any public comment on the motion to approve the agenda? Any comments from the phone?
No comments over the phone.
All right, thank you. Ms. Toof, can you please call the roll?
Dr. Bolat? Aye. Dr. Bishop? Aye. Judge Feinstein? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines? Ms. Sutton Wills? Mr. Wormuth? Ms. Wright? Dr. Yip? Mr. Serrano Sewell?
Aye, motion carries.
Thank you all very much.
Thank you. Next item, item 20, discussion and possible action on midwifery council appointments. Mr. Warden.
Staff recommends the board approve the MAC recommendations to appoint Anna Marie Adams to the vacant physician member position. Staff also recommends the board approve the MAC recommendation to appoint Jocelyn Dugan to the vacant MAC public member position. And staff further recommends that if the MAC at its August 18th, 2016 meeting recommends a licensed midwife to fill the vacant midwife position, that the candidate be permitted to sit on the MAC at that meeting pending the board approval at October 2016. The board's reports on BRD 20-1. The board received 7 applications for the licensed physician position. 2 of the physician applicants were present, and the MAC chose recommended Dr. Adams for the position. I'd like a motion to approve Dr. Adams.
So moved.
Colleagues, if it pleases you, perhaps we can take up, I'll first ask, are there any questions about the 3 matters? Yes, Dr. Yip?
Is she the only one? Yes, she is. It's one of the requirements that they look for the MAC, is that the physicians who apply are OBGYN certified.
All right. Are there any questions about Ms. Dugan's CV? Thank you for that clarification with Dr. Adams. I don't see any questions from the members about Dr. Adams or Ms. Dugan. Are there any issues with the approving the council's recommendations for the licensed midwife member position to sit at the August council meeting prior to our approval? I see none. Perhaps then we can entertain a motion to approve Ms. Dugan for the vacant public member position on the Midwifery Advisory Council, and to approve Dr. Adams to the vacant position member on the Midwifery Advisory Council. And included in that motion is to approve the council's recommendation for the licensed midwife member position to sit at the August council meeting prior to the board's approval.
So moved.
It's been moved and seconded. Thank you, David. Is there any comments from the audience? Seeing no comments from the audience, are there any comments on the phone?
We have no comments over the phone.
No comments. Wonderful. Ms. Toof, can you please call the roll?
Can I just make a
Yes.
clarifying comment? Just, I don't think it changes anything, but the medical doctor who sits on the MAC does not have to be an OBGYN. They have to be a licensee in good standing with the board. But when they apply, they're generally showing interest in serving on the MAC, so it tends to be an OBGYN.
All right. Thank you. Please call the roll.
Dr. Bolat? Aye. Dr. Bishop? Aye. Judge Feinstein? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines? Ms. Sutton Wills? Mr. Warmoth? Ms. Wright? Dr. Yip? Mr. Serrano Sewell?
Aye, thank you. The motions carry. Appreciate it. We'll now move to agenda item 21, Investigation and Vertical Enforcement Program Report. This has two components, colleagues. A program update from the Department of Consumer Affairs and a program update from the Health Quality Enforcement section. Hello. Good afternoon. Thanks for being here.
Morning. It's almost good afternoon.
Almost good afternoon. Yeah, it's still good morning. Thanks for joining us.
Good morning, members. My name is David Chris, and I am the Chief of the Department of Consumer Affairs Division of Investigation, and this is Deputy Chief Kathleen Nichols. We will be providing an update on the division's Health Quality Investigations Unit. It was asserted at the last board meeting that HQIU vacancies were adversely affecting vertical enforcement. We've been analyzing the root cause of our investigator vacancies. They are attributed to two main factors: pay and the VE system itself. Regarding the pay issue, a retention pay proposal for HQIU investigators has been prepared by the division. We are hopeful it will be addressed in collective bargaining process, which is now taking place. In February 2016, HQIU sent a confidential survey via SurveyMonkey to sworn investigators to solicit feedback on the VE program and to suggest improvements to the program. We have shared the survey report with Executive Officer Kim Kirkmeyer and Enforcement Chief Christina Delp, and will be working with the Medical Board and the Attorney General's Office to recommend some improvements to the program to maximize efficiencies and to reduce investigator vacancies. We have also taken active steps to assist with the workload during this time. We have initiated an emergency pilot project to fill 6 special investigator assistant positions statewide. Special investigator assistant positions do not require full peace officer backgrounds and are vital to assisting with investigative tasks such as obtaining court records, medical releases, medical records, serving subpoenas, and providing support for sworn investigative staff. These positions might also identify and develop great potential candidates for our sworn peace officer positions. We have also contacted recently retired investigators to rehire them as retired annuitant investigators. Even though this requires a full peace officer background, these investigators are fully trained and will help with the work overflow. Supervisors are also carrying an active caseload to assist investigators with the increasing caseloads. In addition, we have approved overtime for existing investigators to help manage a larger caseload. We have streamlined the background process to identify any potential issues that disqualify candidates up front, so we can focus on completing backgrounds that will result in successful investigator hires. We are actively filling our vacancies and have upcoming investigator interview panels for several offices. We have also worked with the Medical Board and the Attorney General's Office to develop a new case disposition procedures to streamline our process and to improve processing times once an investigation is complete. This collaboration was very successful, and the new procedures took effect May 3rd. It was also reported at the last board meeting by the Attorney General's Office that the majority of our criminal cases referred do not result in filings. This information was not correct. For the current fiscal year, 2015-2016, we have referred 26 cases for criminal prosecution. 15 have been filed, 2 have been rejected, and 9 cases are still pending filing decisions by the district attorney. For fiscal year 14-15, 40 criminal cases were filed and 23 were rejected. On March 4th, 2016, a complete list of all active criminal cases for our 12 field offices was sent to Senior Assistant Attorney General Gloria Castro. There were only 17 cases involving licensees. 11 were MD cases. 6 cases were other Allied Health Board cases. And the remaining 93 cases were unlicensed individuals and not under the purview of the Attorney General's Office and have no licensing component. The 17 MD license cases represented only 1.3% of our total caseload. In an effort for full transparency, we will be providing the Attorney General's office with monthly spreadsheets of all active cases so that moving forward there will be no confusion as to how many criminal cases are proceeding. I would also like to point out the number of criminal referrals has not significantly increased since the transfer of the investigators to the Division of Investigation. Fiscal year data from the Medical Board's annual report reflect the following data. Fiscal year 11-12, there were 89 criminal referrals. Fiscal year 12-13, there were 122 criminal referrals. Fiscal year 13-14, there were 67 criminal referrals, and in fiscal year 14-15, there were 76 criminal referrals. Although the criminal referrals for the Medical Board cases increased by 9 cases in fiscal year 14-15, that increase is negligible when compared with the criminal referrals from the prior 2 fiscal years. Fiscal year 11-12 had 89 criminal referrals, and fiscal year 12-13 had 122 criminal referrals. The transfer of investigators to the Division of Investigation has not resulted in increased criminal referrals when compared to prior years when the investigators were employed by the Medical Board. In addition, the 76 cases reported in fiscal year 14-15 were out of the 2,016 total cases completed, equaling less than 4% of the total. Out of 76 cases, 39 were MD cases and 37 were unlicensed individuals that are not prosecuted by the Attorney General's office. The percentage of criminal referrals regarding the Medical Board licensees only equaled 2% of the total case dispositions for fiscal year 14-15. However, it is important to understand that public protection includes investigating and referring criminal prosecution, those cases that are so egregious that it merits criminal prosecution and punishment. An HQIU investigation completed for the Osteopathic Medical Board recently resulted in a 30-year conviction for second-degree murder regarding the physician's prescribing of pain medications, which resulted in patient deaths. We currently have several MD cases being criminally prosecuted. One case involved a San Diego physician who sexually assaulted female patients and took explicit photographs of them with his cell phone at an El Cajon clinic for low-income patients. Additionally, we have worked jointly with the Medical Board and the Attorney General's office to develop parallel prosecution guidelines to ensure that public protection is achieved in cases that are criminal. Meetings to develop these guidelines began in December 2015. One of the key functions of this process is that dual referral will be made to the District Attorney's office and the Attorney General's office at the same time. The Attorney General's office will review the case for consideration of filing an accusation and will recommend any additional evidence needed to pursue the administrative case and monitor any statute issues. When the case is received in the field office, the Attorney General's office will continue to review all incoming cases and will help identify those cases that might necessitate interim suspension orders. We will continue dialogue with the Medical Board and the Attorney General's office to improve this process and revise the guidelines to maximize efficiencies. HQIU employees participated in the Medical Board's recent expert training in San Diego on March 19th. We are continuing to assist in this valuable project and are working with Medical Board staff to identify future training dates for the Los Angeles and Northern California area later this year. We have 2 joint training sessions scheduled with the Attorney General's office regarding 805 investigations. May 10th is the Northern California training date, and May 19th is the Southern California training date. This was a collaborative effort that will bring statewide consistency to investigative methods and evidence collection. Also, a cloud-based information sharing system was implemented statewide in April 2016. This cloud-based system will enable HQIU to share data with the Attorney General's office. All case information will be scanned and uploaded to the cloud for assigned attorneys to review and provide feedback. This new cloud-based sharing system will help eliminate communication gaps for document review. We have also established regular ongoing meetings with Executive Officer Kim Kirkmeyer and Enforcement Chief Christina Delp regarding important HQIU issues as they develop, and have given status updates on critical items. I also wanted to say a few words about our exceptional staff. Our investigators are our most important resource resource. HQIU cases are very serious and complex, and our investigative staff is very educated, very experienced, and skilled at working this type of casework. They have persevered despite staff shortages and system challenges. They are true professionals, and I am very proud of them and proud to be their chief. Do you have any questions?
Yes, we do have questions.
Okay.
Thank you for that report.
Just a comment and then a question. Comment is that at the FSMB meeting, we had multiple people who talked about that doctor who was prosecuted, that the osteopathic doctor who was prosecuted for a second-degree murder. So that was very enlightening. I think you should, that would have been even better if some medical staffs and other people see it. It's not easy to prosecute a physician for a murder. So that was very enlightening, because if there was any doubt in my mind why the doctor was convicted for second-degree murder, it went away. My question is this. I still can't see this graph going down. The days is still going up rather than flattening, and hopefully next time you come, it will start going down. That's what our goal is, to cut down the number of days it takes to finish the investigations.
Yes, and I'd like to comment on that as well. And that's, I took this position in January. Our staff has made an incredible effort to get some of these projects to help update and to help streamline our processes. And we've been working hand in hand with Kim Kirkmeyer at the board and with Gloria Castro at the Attorney General's office to put some of these things into play that'll help reduce those times. And so it is, I think those efforts going forward to streamline and to update will help decrease some of those times. So I look forward to reporting those decreases as well.
You referenced your hiring efforts.
Yes.
Yeah, challenge. Thank you for doing that. What's the vacancy rate right now? What are you?
Our vacancy rate is 36%. It's 28 investigator positions. However, we have 9 investigator candidates in background and an additional 4 being vetted for eligibility determinations. And we've scheduled ahead of time several investigative panels to keep this process moving forward. But additionally is the background process and the hiring process does take some time, and that's why we move forward expeditiously with this pilot project for the investigator assistants. I think that's immediate. It doesn't need a mandated peace officer background, and so we can put those people into play right away, and that is being done as we speak. Sure, you could. Kathleen has some comments.
I just wanted to give you an update on the actual interview panels we're hiring. I'm personally attending all of these interview panels because it's such a vital part of rebuilding our vacancies. But we had investigator interviews April 7th for Valencia, April 8th for San Bernardino, April 14th and 15th for the Fresno office, April 28th for the Tustin office, and scheduled coming up. On May 9th, we have investigator interviews for the Operation Safe Medicine and Tustin offices, May 12th and 13th for the San Dimas office, and May 26th and 7th for the San Jose office. So we are very aggressively setting up these panels and trying to hire qualified candidates.
Dr. Lewis?
Along those lines, how many candidates are showing interest in the position? Because from what I heard previous board meetings, is your salaries are still not competitive, and you're in bargaining now, as we all are in government, but there's a problem with the salary and being able to track people. Is that true still?
Well, that's still true. The salary is an issue. So we're very hopeful that the collective bargaining process, which is happening now, might rectify that part of the problem.
It's almost like you want to lean on someone to help support that, because, I mean, money is tight in the state. You know, you get very little, even in collective bargaining. But as I said a comment yesterday, it's almost like you want somebody in legislation somehow to kind of be your advocate. And I just make that comment again because otherwise you're not going to attract people. They'll go to CDCR, which pays more money.
All right.
Okay, thank you.
Thank you. Are there, yeah, Dr. Levine?
Just a question, have you put in place any formal retention strategies for the staff you do have who are committed to the work? Are you thinking about things like that?
There was the retention, it was part of the proposal to propose an increase for those investigators who are field training officers, and also the salary increase. That was part of the recommendation. And then we also had the survey to help identify from investigators what are the things that are causing them job dissatisfaction. And we intend to work very aggressively on that with Kim Kirkmeyer, the medical board, and Gloria Castro with the Attorney General's office to make improvements, to make them want to stay, the ones that we have.
I'm sorry, I'm thinking beyond money, and I understand the issues with the vertical enforcement, but there are other things, HR things that you can do that don't cost a lot of money, that communicate that these people are valued, respected, and, are recognized for the work they're doing on behalf of the state.
Yeah, thank you. We will actually incorporate that as part of our project that comes out of this survey.
There actually is one thing that's in play. We're implementing a continuous improvement team, which is going to be comprised of a handful of investigators from each area, and that team will work on several different things, but one of their first projects is actually talking about a retention recognition system, because it was discussed that when employees leave, we, take them to lunch and we say goodbye to them, but whatever happens to the ones who stay for 10 or 15 years? So part of that small group is going to be deciding those exact things, what things other than money maybe could be done to help recognize those people. So hopefully we'll have some updates at future meetings about that.
Dr. Bolot?
Yes, well, thank you very much. And just for reminding me, can you tell me your recruitment process? Because on the back end, what Dr. Levine mentioned is how important it is to value those employees that stay. And I think that's a challenge for everybody. The A people kind of don't get recognized, and we spend our time on the C-level people. So at this point, what are you doing that would make this an exciting reason to join your team? What's your recruitment package?
First, we advertise it's a peace officer position. Background is required, and through the government code by the state. The knowledge base and education that are part of the minimum qualifications attract people who are passionate about that work. The cases are very interesting. Lots of training is given, and correct me if I'm wrong, it probably takes about 3 years to get somebody who's got enough training and experience to handle a full caseload. So we try and recruit. We have 3 different web-based systems that send out that information, say, hey, we're looking for these type of candidates. We go to career fairs, we go to colleges, to academies, and try and recruit people who are interested in these types of cases. And we are successful in we do have a core group of people who are very knowledgeable and very educated and very experienced. Once upon a time, I was a medical board investigator, and I really liked it. I enjoyed the casework. It was exciting to work in the office with the physicians and our expert reviewers. A great many of our staff feels that way as well. There has been system challenges and pay challenges, and so I think that we are aggressively trying to overcome those. And have been successful immensely, I think, since January in getting 3 of these projects moving forward. So moving forward, I am very optimistic, and I do expect retention and success.
And that to fill up that 36%. And last question, if I may.
Please.
The other piece to this is you mentioned the assistants, because many times what's happening in medicine, it's happening in many industries, we said we need an X to do Y. And sometimes other people can do a lot of the work, and that we make sure that people in medicine, we like to say we work to the top of our license. So I would love to hear more at some point about what your folks are doing to support your investigators? Because I'm guessing there's a lot that could be done that could maybe close that gap of your 36%. So thank you.
Thank you.
Yes, Judge?
This may be a little bit of a question far afield, and I apologize if it is. Do you have any estimate, just on the fly here, as to the number of cases you have that are pending either referral for criminal prosecution or are already in simultaneous criminal prosecution? A percentage or a number?
Yeah, it's for criminal prosecution, it's going to be around 2% of our cases. We roughly have around 2,000 cases per year. So it's at 2%, which is very low. It actually, if it was under 10%, I'd be very happy. So, this is something that is important to address. Some cases are so egregious on the front end that they need criminal prosecution. And I think it was good to take a look at that and to create a parallel prosecution policy jointly with the medical board and the Attorney General's office to look at those cases up front and do what action needs to be taken immediately. If a suspension order needs to be put in play immediately, to take that action and to work with the DA at the same time. So work jointly with the Attorney General's office and the district attorney.
And I would presume it slows down the administrative portion. I mean, obviously, if someone's convicted of second-degree murder, their licensure isn't really a right question, because it's been answered. But in terms of general cases, the DUI cases or those kind of things, there are not enough of them that they're slowing you down, that they're affecting the numbers.
No, it's a very small percentage.
Yes.
I just want to let everyone know, too, that this hasn't gone unnoticed by us over at the medical board either. And we've talked to Ms. Nichols and Mr. Chris and Ms. Delp and I. We're kind of looking at right now, we still have about 4.5 positions that were our non-sworn positions. As you all know, we started our non-sworn unit last year in 2014, in July of 2014. They've done some excellent work. I think Gloria would admit that, or Ms. Castro would admit that those cases are really well packaged and everything put together. So we're actually looking at expanding that unit and taking some of the less complex cases from HQIU to where we can pull some caseload away from them. We found that, we're able to move them faster just because we don't have the large caseload and we have the staff. But we do need that some probably in the southern area, because right now we have those individuals traveling all over the state. So we would probably have to open up a southern unit, but that's something that we're looking at. It's just we've been trying to kind of get everything else under control first, and then we'll start looking at that where we can actually implement that.
That would be very helpful. Thank you, Kim.
Thank you. Good collaboration. Are there additional comments or observations from the members? Thank you. We'll now go to the second part of item 21. Program update from HQE. Ms. Castro. And thank you for that report.
So good afternoon. First off, I want to echo Mr. Chris's and Ms. Nichols' commentary about the collaborative efforts that we've undertaken since they took on the leadership of HQIU. Myself and my management team and all of my DAGs and lead prosecutors are very happy with the leadership. I would like to report that as of our last report to you regarding these criminal investigations, all the issues that I raised to you in this forum have been met with my satisfaction, and all of my concerns have been addressed. Putting the public on notice, I'm putting several pots in the fire, so to speak, administrative and criminal where necessary, such that every single possible avenue can be pursued. And in case a criminal prosecution does not go forward or is dropped or settled, we already have something disciplinary at the same time. And so we have definitely appreciated that transfer of information to us. I'm happy to see that some of my favorite investigators are still with HQIU. I got to see Elizabeth Costello, John Janens, Tracy Tu, and Christopher Figueroa. And these are very elite investigators that have a very highly technical background. And I am not surprised that they are being wooed away by other agencies that want those skills in their shops. So with that, I'm very happy with HQIU and their leadership. At the same time, I meet with Ms. Kirchmeier and Christina Delp to continue to discuss data reconciliation efforts and any efficiencies that we can put into place at the Complaint Investigation Office, as well as the probation unit in the headquarters section of Ms. Kirchmeier's office. I know that there is a lot of attention to the statistics, which HQE also shares with HQIU. We have a total of 1,157 open and active investigations in our office. Of those, you probably see half of them represented on the statistics. But what you don't see is all the efforts, even in face of 36% vacancy rate by investigators and our deputies trying to assist the new people coming on and also being very patient with the folks that are overburdened. And as such, the work continues. We still continue to get transfers to our office on amendments to existing accusations and also new work. And with that, that concludes the first part of my report on the vertical enforcement program. And then I'll move on to the next
Okay,
part.
and I'm going to ask if any of the members have any questions about the vertical enforcement component, and then also see if there's any public comment based on those two
Right.
reports, and then we'll go into your update. Is that okay?
You're the boss, yes.
Thank you. Are there any questions from the members on the first part of Ms. Castro's report on the update from HQE? I'm looking to my left, to my right? My left, that was my right. No questions? Okay.
All right.
I'll ask if there's any public comment from this. This would be 21A and B. Seeing no public comment from the audience, are there any comments from the phone?
If you have a comment over the phone, it's *1. No comments at this time.
All right, thank you. Well, we're now at item 22.
Yes, item 22 is very brief. I wanted to thank the medical board for providing a letter to one of our most elite supervising deputy attorney generals, Jose Guerrero. We were very pleased to see Ms. Kirchmeier there, and I think it meant a lot to myself and my staff to know how much you appreciate our work, because we've certainly focused on a lot of the negatives, but there are more positives than anything else. So thank you to the medical board for providing that letter. I also would like to report that after 30 years of service, Vivian Hara, who had been a supervising deputy attorney general in San Francisco, has retired. It's very, very hard to lose really qualified folks like that, but they left the seats behind for new people. New staff, we have two new DAGs, Brian Bill and Nicholas Schultz, joining our Los Angeles office. And more recently, our Attorney General, Kamala Harris, was able to promote qualified Deputy Attorney General 4s to a new position of Deputy Attorney General 5. And I think for folks that have been struck with the bug or genetic defect of voluntarism and public service, it's always very nice for morale, obviously, to get this 5% boost in pay to recognize their efforts. So whatever you can do to recognize the investigators as well would be great. Hiring above the minimum, doing anything like that. I know I'm going outside of my lane to make that suggestion, but I wanted to let you know that our deputy attorney generals and our investigators do not get paid enough for the work that they do, and they do it because of the love for public service and for public safety. So with that, that concludes my attorney general report.
Are there any questions from the members? Yes.
Just a comment, Ms. Castro, we do appreciate what AG's office does. As far as this board, I can speak for me and also for the board, we look at the entire DOI and DCA, AG's office and medical board. It's partners. The only way we can really resolve issues on these delays, how long it takes, hiring people, all is actually working together. So we're with you, but I still want to see those graphs going down. So.
All right.
I am not going to make any guarantee, but I do believe that that graph should be going down with the three important initiatives of data sharing, efficiencies in the case disposition process, and other efficiencies in the complaint investigation office, so that we can work miracles with an understaffed and overworked folks.
See no additional comments. Thank you for that report.
Thank
Very
you.
much appreciated. Are there any comments from the public for Ms. Castro's report? Seeing none, are there any comments from the phone?
Once again, it's star one if you have a comment. Looks like we have no comments.
All right, thank you. We'll now move to item 23, discussion and possible action on proposed regulations on citable offenses, citation disclosure, and citation and fine authority for allied health professionals, amending Title 16, Division 13, CCR Sections 1364.10, 1364.11, 1364.13, and 1364.15. Ms. Delp and Ms. Webb. Ms. Webb.
I'll be speaking on this,
Thank you.
and I'm so glad you stated all the section numbers, so I don't have to. This is on tab 23 in your book, and the board staff is looking to amend the cite and fine regulations in a number of ways. First, we want to add licensed midwives and polysomnographic technologists, technicians, and trainees as individuals that board staff can cite and fine. The staff also wants to add certain code sections and regulations where if the licensee or registrant violates them, they can be cited and fined. There's some additional comments, but I want to be specific. Under 16 CCR 1364.13, that's another area where staff wants to add licensed midwives and the polysomnographic folks to address unlicensed practice situations. And also, under 1364.15, because of a change in statute, the citations are on the website 3 years, not 5 years, so the regulations need to be amended to reflect that change in law. I do have one suggested amendment under 1364.11, and this would also apply to 1364.13, where at the end it says, the sanction authorized under this section shall be separate from and in addition to any other civil or criminal remedies. It should state to any other administrative, civil, or criminal remedies. That would be a suggestion to the written changes here. And with that, happy to answer any questions, but staff is requesting authorization to move forward with the rulemaking process to formally notify the language with the suggested amendments and to set the matter for hearing at a future board meeting.
All right. Are there any questions? Deb?
Just make a motion to authorize the staff.
Second.
All right. There's been a motion and a second. Are there additional comments from the members or questions? No? Seeing none? Are there any comments from the audience? Or any comments from the phone?
And as a reminder, it is star one if you have a question over the phone or comment.
All right. Ms. Toof, please call the roll.
Dr. Bolat? Aye. Dr. Bishop? Aye. Judge Feinstein? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins? Yes. Dr. Kraus?
Aye.
Ms. Lawson?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines? Ms. Sutton Wills? Mr. Warmoth? Ms. Wright? Dr. Yip? Mr. Serrano Sewell?
Aye, the motion carries. Thank you. We're now at item 24, discussion and possible action on proposed regulations on requirements for physicians on probation, amending Title 16, Division 13, CCR, Section 1358. Ms. Webb?
This is a regulation that had just very old language in it, and so staff is looking to bring this up to current times by striking the word division and replacing that with board. Also, our probation unit is not the probation surveillance compliance program, it's the probation program. And the board obviously no longer has the investigative personnel that this is referencing. In addition, we want to broaden it. This referenced that the probationer needs to be compliant with requests for biological fluid testing, and just adding another reminder that they're expected to be compliant with each term and condition of their order placing the physician on probation. So with that, staff is seeking authorization to move forward with the rulemaking package, notice the language for public comment, and set the matter for hearing at a future board meeting.
So moved.
It's been moved?
Second.
Seconded? Thank you. Is there any questions or comments from the members? Looking to my left, to my right? See none. Are there any comments from the audience? None? Are there any comments from the phone?
And once again, it is star one if you have a question. I do believe we have a question. Tina, do you have a question?
None. Okay, thank you. Ms. Toof, can you please call the roll?
Dr. Bolat? Aye. Dr. Bishop? Aye. Judge Feinstein? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson?
Yes.
Dr. Levine?
Yes.
Dr. Lewis?
Aye.
Ms. Pines? Ms. Sutton Wills? Mr. Warmoth? Ms. Wright? Dr. Yip? Mr. Serrano Sewell?
Aye, the motion carries. Thank you, Ms. Webb, on those two items. Appreciated. Colleagues, we're now at agenda item 25, agenda items for the July 2016 meeting in the San Francisco Bay Area. At the top of my head, I know that we'll have an End-of-Life Option Act presentation, the regulatory hearings, which we've just approved today, and elections of officers. I'd also like to add, if I may, Ms. Kirkmeyer, an update on the ISO presentation that we had, it would be about a year ago at the July meeting. And again, I'll work with you in getting an update and staff on where we stand with that report. Look to my right, and then I'll look to my
Yeah,
left.
Mr. Serrano Sewell, so I would like to add an item for the staff to start looking into. One of the things which was brought up at the Federation of State Medical Boards meeting was trifecta board collaboration, that is the nursing board, the medical board, and the pharmacy board. I think it's time we should start looking into, especially with Barbara being there, it even makes it a little easier. So you can get a lot of things done if we start working with each other. So I would recommend to the staff to start looking into.
Okay. Dr. Kraus?
I have several items for the San Francisco agenda. One is also at the Federation of State Medical Board meeting. The Federation adopted two policies with respect to marijuana, and I'd recommend that we discuss these issues at our agenda. One was in relation to guidelines for physician recommendation of marijuana. I know we already have policy on that, but I'd like to consider whether or not that needs to be revised or amended. And the other is a guideline that they've established for physician use of marijuana, and I'd like to address that as a separate agenda item as well. In addition to that, at this meeting's Enforcement Committee meeting, especially in light of our having new board members, I noticed that there were many questions regarding terms of probation and oversight of probation. And if not at the San Francisco meeting, perhaps at some meeting soon, we could have a informational report on what's involved in oversight and verification of terms of probation. That would be helpful.
All right. Any more? Thank you, Dr. Kraus. Ms. Jamie? Ms.
Can
Wright?
we get an update on the demographic study that's being
Yes.
conducted? Thank you.
Thank
That
you.
would be great.
Yeah.
And
Dr.
Jamie, there is one actually in the enforcement program summary, written one, just so you know for this meeting.
Okay.
We'll have
But by then it'll be an
We'll have a
additional
presentation.
3 months. Yeah, so if it could be like a full presentation, that would be great.
We'll do that. Dr. Levine?
I was interested and appreciate the report on improvement or the changes that are going to be underway for vertical enforcement to try and improve it. And I wonder if we might just have a narrative of what those are and what the likely outcome of those changes or improvements will be as part of the report at the next meeting or subsequent meeting.
This is not your only chance to request agenda items, colleagues, but this is when we try to capture some. Ms. Palat? Dr.
Yes,
Palat?
just very quickly, I wanted to look at and consider how we are training, if any of our medical schools or residencies or even our fellowships are training our physicians as to what I think Dr. Lewis and Ms. Kirchmeier were doing. And they were asking good questions about, so what is ethical conduct of a physician? We can't teach that necessarily, but it would be in, let me rephrase that. People are ethical or they're not, but if you don't know your standards, I think it's very important. Most of the young physicians that are in training don't.
Okay, thank you. Ms. Chung, did you want to comment on this? The speaker's card.
Yvonne Chung with the California Medical Association. We'd like to request the addition of an item for the next agenda. Pursuant to Government Code Section 11425.60 and procedure that the Medical Board has adopted, CMA is requesting that the Medical Board consider and designate a certain decision as precedential. We're asking that the Medical Board's decision in re Gary Igor Razon, dated March 20th, 2015, be designated as precedential because it contains significant legal and policy determinations of general application that are likely to recur. We've provided a copy of this decision to the Medical Board staff, and we'll be providing a written request to the board and staff to explain the reasons why this decision should be precedential. In case you're interested, the decision actually relates to the circumstances under which a physician would be practicing within the standard of care in prescribing drugs for off-label use. Thank you.
All right, thank you very much. We'll take that under advisement. Are there any additional comments from the audience on agenda item 25? Seeing none, are there comments from the phone?
We have no questions or comments over the phone.
All right. Colleagues, before we stand adjourned, I want to first thank you for being at this meeting, and I thought it was very productive. We got a lot done. Appreciate that. And also, again, welcome to our new members. Also, thank the public for being here and participating in the dialogue. And thanks staff for doing another spectacular job of supporting this productive meeting. I just want to call people out. I'm just going to do first names because there's a lot. Thank you to Carrie, Diane, Lisa, Kirk, Regina, Dino, Liz, Christina, Jennifer, Ann, Regina. And we have some investigators here. If you're still here, please stand. Bob, Tracy, John, and Chris, thank you for being here. Thank you so much. And our video guy, Lou, over there to my left. You've all done a phenomenal job. Thank you. And I just want to close with one final observation. When I make those introductory comments at the beginning of each meeting, what is, I think, unsaid in that is that this board, which I think does an exemplary job of conducting its affairs with the utmost respect for civility and decorum. And that brings out the best public policy in my mind. And we shy away from ad hominem attacks or ascribing motivations to individuals or organizations. I think that detracts from getting to the best public policy. So I know we'll continue to do that, and That'll motivate the public as well to keep it on the policy. With that, if there's no objections, the meeting stands adjourned. Thank you.